pride in. Thank you for the discussions that we had yesterday. Very fruitful, very engaging. Thank you for the insight and wisdom. And Lord, today as we start off, we welcome your wisdom, we welcome your presence, that you will guide us. As we serve this great nation, we will be very useful for the citizens that you've given us to serve. We pray that guide the facilitators, guide us, providing good health and strength to go through the day. We pray that you will also help those who are coming, who are still on the way, that they will find their way here quickly, that we may go together. We commit this day unto your hands, for it is in your wonderful name we pray and believe. Amen.
Thank you, Caro. Just hold on to the mic. Kindly, if you just came in today, raise up your hand. Just introduce yourself, your names, if you are a CC Health, or if you are our stakeholder, and then which county you are coming from. Meanwhile, Dr. Wamalwa, kindly be with you.
Good morning. Apalia Anthony is my name, from Turkana County, CEC. Sorry for coming late. Sorry.
Welcome, Apalia.
Good morning, everybody. Dr. Sore. I don't know which county I come from, but I'm here to facilitate from formerly Nakuru County as the director. I was seeing Pepela here, also partly Kitale and Kakamega. So, thank you.
Karibu.
Dr. Gregory Ganda, CCM Health and Sanitation, Kisumu County. I came in late yesterday, around 4 p.m., so not today. Thank you.
I wish you joined us because we left here at 7:30. Oh, you are here?
Yeah.
Oh, okay. The hall is too full. It's too big, eh? There's a hand up.
Good morning. Mimi naitwa Javan Bonaya, CC Health and Sanitation, Tana River County. Nilikuwa hapa kutoka jana. Asanteni.
Karibu Java. Javan. Javan also bounced back.
Professor is telling me, Paul, I don't know why.
Okay, thanks.
And it is true, we have an outbreak of cholera in Tana River. We've lost some, as at yesterday, about 7.
Oh.
Yeah, 7.
Polene. Any other guest in the house? There is a hand there at the corner. Secretariats kindly have mic. Maybe you can manage these two. She can manage the other two.
Good morning. My name is Erica Adhiambo. I'm from Homa Bay County. I'm the technical advisor to Minister Roslyn Omolo.
Okay. Thank you very much. Karibuni sana wenye waliingia leo na jana jioni. Yeah, there's a hand up.
Good morning.
Morning.
Dr. Joseph Wahome Mukundi, representing CC Meru as the Chief Officer of Health, Acting Chief Officer.
Okay. Karibuni. Karibuni. I know we've done a lot. For those who have came in late, you can still catch up with us. We have a lot of materials. Maybe just check the bag that you are carrying. It has a reference manual and abridged version of the manual. So you can quickly just go through and see maybe what you've missed out. But again, still we have presentations that you can be able to share on the wall. So secretariats, kindly start sharing. But as I said earlier yesterday, kindly share, put all your details so that we start putting you into the email communication. So at this juncture, our moderator this morning will be, Dr. Shikeli will join us late, but I'm going to invite Regina Ombam, a very senior finance technical expert. She worked with us and supported us at the Secretariat, But now she will introduce herself. I don't want to say, let it come from her, but she's our international guest, if I may say. So karibu sana Regina. I know this session will be very interesting, and Regina is up to the task. I know you are not going to get bored. So prepare to dance. Prepare to dance and prepare to make your waist flexible. Karibu sana.
Good morning, everyone. Regina Ombam is my name. I will be the moderator for this session. As Katra indicated, I supported the Council of Governors as a health financing expert, and through that I was able to move now to the East Africa region as their health financing expert. So this morning, ladies and gentlemen, we will start off with a host of presentations. I will request that we don't have to keep calling everybody once their turn is ready. So we will start with Dr. Wamalwa. Dr. Wamalwa is a public health expert at the COG, and he will be making a presentation on health sector governance. Following Dr. Wamalwa will be Dr. Mutaha Kangu, who is in charge of intergovernmental relations as an expert at COG. He will be presenting on health sector partnership and coordination structures. And then we will have Katra Ali, who is a director of health services at COG, who will make a presentation on health committee role and linkages. Then we will have Walter Tito making a Maarifa presentation. I would request that if we have any questions, please jot them down so that once these presentations are done, we can have an interactive session where these questions can get answers. Then we will take a health break and then come back for the next session. Without much further ado, ladies and gentlemen, allow me to welcome Dr. Wamalwa on the stage. A round of applause for Dr. Wamalwa, please.
Yeah, thank you very much, Regina. So as you realize, this morning we'll be talking about health sector governance. And I'll do the first part of the presentation, basically talking about the organization of Kenya's health sector, and then discussing a little bit about some of the governmental actors within the space. And then we'll have Dr. Mutaha pick up that, talking about intergovernmental relations, and finally Katra talking about more the role of the COG Health Committee. So that's, if you look at your manuals, you realize that this is very clearly articulated in chapter 3 of that manual. So I'll basically be the first one to go, taking the first part of that. And I don't know if I can get a microphone that allows me to move around. We are doing this at a time when you just got appointed and came into office, and we do understand that communities out there and your governors expect results from you. The other thing I would like to note is that we also exist at a point when Kenya is changing. I mean, we have a number of dynamic things. One thing, I'll not point out all of them, but one thing is, of course, the realization that we have an economic situation which is changing. From 2015, we have been classified as a middle-income country, and as much as I've had a lot of Kenyan citizens doubt that status, and some question, I mean, it's a fact that happened based on certain objective analysis. And because of this, we have a number of things. One is that we have changing trends. I'm sure a number of you have been engaged in the discussion around donor transition, making more optimal results from investment by different development partners. We've been talking about a greater role in health of government. Already government is taking a big role, but we are talking about expectation of taking a greater role of this, even within a space, a fiscal space that is very limited for county governments. Yesterday, the chair of the health committee, His Excellency Governor Mudomi Njuki, noted that most counties, if you look at most counties, we are already spending over 30% of the budgets on health. And I think it was Professor Okwaro who said that we are looking at making money, talking about more health of the same money coming out. So quite a tight space there, even as we talk about this. But with the economic dimensions that I've talked about, we do have some sort of an emerging private sector, probably not fully emerged, but an emerging private sector that is vibrant, that can contribute, that is and also claiming a little bit bigger role in terms of its responsibility in health. And when I talk about private sector, a lot of times people only focus on those hospitals that are providing services directly to patients within your counties. But really what I mean is private sector in its very own meaning, in a broader sense of what it means, both within the health space, but also without the health space, outside the health space. And this basically puts us into, as health leaders and managers, gives us a challenge of how to think and innovate and co-create with those actors to see how and what role they can play when it comes to health. And then we have, of course, increasing disparity. We have a growing middle class, which means something in terms of income for governments. But also, we have a population which is growing of people who have a difficulty of accessing and affording their own basic health. So we have increasing disparities, and we have some people having more money. So I think there's a dynamic there that we need to think about. So there are more people that you need to actively come in to support through social insurance and other mechanisms. But there are other people who are growing up who can actually pay for their own health care. So a more dynamic and differentiated platform is emerging. And this is even more for cities like Mombasa, Nairobi, Kisumu, Nakuru, but also true for even rural counties. Waziri from Nandi, I think Waziri, you referred to Nandi as one of the emerging rural counties. But even when you go to that county, you realize these disparities emerging very quickly, quicker than we have seen in many years. The other thing to note that I want, this just to base my platform before I talk about how we have organized our health system. The other important thing is the burden of disease that we face. We tend to live at a time when, yes, we still have communicable diseases, as Waziri Tanariva is saying. We have cholera, we have malaria, we have all these other communicable diseases that come and go. We have more longer-term diseases like HIV, like HIV, of course, TB, malaria. So we still have communicable diseases, but we have non-communicable diseases and injuries as a major incoming player. If you look at the top 10 diseases currently, then you realize that we have a significant portion of disease, death, disability that can be associated with non-communicable diseases. So non-communicable diseases and accidents are more important now than have been in the past. And projections, if you look at projections moving forward, we expect that this is a role that non-communicable diseases are going to incrementally play, even as we move towards 2030 and beyond. So that's quite an important thing, especially given that the costs around managing some of these diseases that are chronic and longer term can be immersed to public health systems. Then the population structure, Dr. Sheikh yesterday talked about a few dynamics around the structure that we have, and noting that different counties have a different population structure, which means that your priorities might innately be different. But on the overall, we have seen population structure that has quite a number of youth. So we have a youth bulge emerging. We have a senior citizens available, growing population of senior citizens as a proportion, not too much, but as absolute number because of the big population of Kenya. You realize that this is becoming significant, and sometimes you can be tempted to ask whether our health system is well prepared to deal with senior citizens. For those of you who are lucky to have fathers or mothers or aunties or uncles and category, I'm sure you would find sometimes them having reservations when you take them to your local doctor or nurse or dispensary, because sometimes senior citizens need to be handled a certain way. So our healthcare workers is our health system as we move, and not necessarily the majority, but a significant proportion of people being beyond 70, 80, 90. How well are we prepared to adequately work with and provide services to senior citizens in this country? Something that we need to talk about, but also people with disabilities. We had the CEO of the council here, and how prepared are we? A lot of times when we talk about people with disability, when we talk about our facilities being compliant, what we actually mean is physical disability. But what about the widespread of things, of disabilities? How prepared and how ready are we? We live in an era where technology is moving very fast. A few years ago, we didn't have mobile phones. We had to go to those red things to make a call. I'm sure all of you remember. Now you can do things on your mobile phone that computers can do. And just if the spirit there is quite fast, and there's room for us to take advantage of the technology world to create a lot of impact. So how well can we transform that? Of course, with every opportunity comes risk. So the necessary need to think about that. And then finally, what I would like to mention is just the major goals, global goals, local goals, things like Vision 2030, our own targets as counties. For example, yesterday you had an aspiration of having all counties having FIF fully enacted by next year. So we have a lot of goals that we need to think about. Some of these are at the global level, some of these are at the national level, some of these are actually as counties, as a family, as a devolution family, we aspire to make these steps ahead. So our hope is that as we talk about this, then we can be able to build up a governance system, a structure that can be able to support some of these realities and contexts. And yes, devolution has been alive, I think, in Kenya for about 10 years. But when you look at the comparisons that a lot of people tend to make, we tend to make on a centralized system that has existed for, is it 60 years? Somebody mentioned 60 years. I normally talk about 100 years because Kenya became a protectorate of the East African Protectorate, I think, was formed in the late 1880s. And if you look at the governance systems right from that point, you start seeing aspects of centralization. And it becomes more elaborate in 1920 when the colony of Kenya is formed. So it's much more years than independent Kenya has existed. So basically when you're drawing a comparison between counties and national government, or a centralized system and a devolved system, you'll see you need to be alive to the fact that people will be comparing some of the progress without necessarily looking at equals. In my culture, children of 10 years, people of 10 years are called children. So you are still emerging, you are still learning, you are still starting to grow. Professor there, I can see smiling. We tend to share a culture, I think. This is just to show that sometimes we think about people at the health facility, but we might forget some of the things outside the building. You can see one saying that I cannot enter with my wheelchair. Another one, I don't have a carer to come with me. So you might be wondering why this fellow is not coming, but it has nothing to do with your health facility not having drugs or not having a person. It's about him not having a carer. And another one is what we're talking about, who will look after my children when I leave. And people have responsibilities. It could be children. Where I come from, even chicken and goats could deny you access to go to the health facility. So when we are planning a system, it's important for us to figure out some of these things and to think that a health system, a good health system, is basically one that is built around the individual rather than one that is built around us or as managers or health workers. And in Kenya, it's increasingly being common for health systems to be built around other things other than the citizen. So I think we need to be alive to some of these things. Now, just to mention a few things that then drive us into the discussion around the structure of the health system in Kenya, and I will talk about that part of that because, as I said, Professor Mutaha will talk about the other, especially talking about intergovernmental relations and contributions of private sector, the donor community and others. But I'll focus more on the governmental side of things. So one of the points to look at is the fourth schedule, which really points out the functions allocated to the two levels of government. The national and as I say that, it's important to note that there are some other areas of the Constitution that could allocate you functions. So the fourth schedule is a very good place to go, but it's not exclusive. So if you read, and the lawyers in the House could comment on that, but that it's not just that's not the only place. You could have other sections, meaning that you have a certain functions, but this is where primarily you need to go. And if you look at this, then you acknowledge a good division, but I want to also mention that even as we do that, even as the primary responsibility of health services in Kenya remains with government, we need to acknowledge that non-state actors have played and play a major role in Kenya's health. So that is something that we need to underline and ensure that we do better coordination even as we move forward. And when I talk about state actors, mainly county governments, the ministry, but also other allied ministries that affect health. It is sometimes common, for example, to find the Ministry of Health and the person doing health and somebody else doing sanitation and water and bits of health that are put under environment. So the structure of government is dynamic, and you know that the Constitution provides that role to someone. The president can organize government in different ways, but basically the ministry is responsible for health, and also there are state corporations there that are state. And then in the non-state actors, we have development partners, we have private sector, NGO, FBO, CBOs, professional associations, which we as a sector have not very much engaged in, and I think we need to engage better. There are some that operate more than unions than providing actual professional advice to government. And I'm not saying unions are not important there, but basically we need to see how to leverage better on professional associations, because they have a group of people with specific technical skills, and this can be extremely useful. And I think this is one area we haven't really utilized as government. Probably just one or two professional associations have been active and generating insights that help. But a lot of others which exist never put forward important information that can help us as governments to run and change and improve things. So we probably need to be more aggressive in reaching out to that. Sector coordination is critical because you have so many actors, and Prof will be talking about that, so I don't want to talk about that. Just to note 176(2) of the Constitution that requires county governments to decentralize functions as far as possible, of course considering practicability and efficiency. These are the county functions in the fourth schedule. So I'm sure you have looked at this. The primary health functions, but also there's a spread of other functions that you might be interested in. For example, under agriculture, plant and animal disease control of habitats, this can affect you. Health, noise control, and other public nuisance, under control, liquor licensing and recreational facilities that can affect health. Primary education is an opportunity for health, and child care, disaster management, control of drugs. So what I'm pointing out is that the point number 2 under fourth schedule, functions of the county government, all those functions are of interest to you, but also as you read the fourth schedule, you might be interested in other things which are not directly highlighted as functions of the county, as county health services, but that actually affect health. So that's the point there. The function of the national government are these main primarily national referral facilities, health policy, capacity building, and technical assistance to counties. But if you look through the functions, the total functions of the county government, then you tend to find some others that are interesting to health, for example, consumer protection and disaster management. I won't talk about 185. I think Prof talked about it yesterday, so I'll just move on and go to how we are organized as a health sector. And you can look at different perspectives. I'll just throw in very quickly some perspectives you need to think about when you are looking at the overall organization of the health sector. One is, you can look at services offered: promotive, preventive, curative, rehabilitative, palliative care. I've highlighted palliative. I've highlighted there I think let me continue. Yes, I've highlighted palliative care specifically there because it's one thing that if you look at across, we are not doing very well as a country. Of course, we have gaps. We have major gaps in preventive, promotive. A lot of that has been talked about, and I'll talk about that a little bit better there. But specifically, if you look at palliative care, we have a lot of gaps there. So it's something that we need to look at, even as the proportion of patients, people who need access to palliative care increases. I thought I had 1 hour. I've only been here for 15 minutes. Okay. The second thing is the level of the facility. And if you look at 1, 2, 3, those are primary care facilities. And what we are looking at is we want to address issues more at that upper level rather than coming to the primary hospital, your sub-county hospitals and your tertiary hospitals. Self-care is a concept that has recently emerged. For millions, not millions really, for a long time, hundreds of years, people have all taken care of themselves. But the health system for a long time did not recognize taking care of yourself as a part of the health system. In 2019, WHO drew the first guidelines of self-care. And in this country, we've started doing some guidance around self-care in reproductive health, in family planning, asking ourselves, what are the best, if you wanted somebody to take care of themselves, if you have a number of health services, and you ask, who is best to do what? And of that, there will be things that a health worker is best to do, but there'll be things that a person, an individual, can do on themselves. So, identifying those and facilitating the individual to be able to do some of those things so that, one, because they do them better sometimes because of privacy and other things, but two, so that they reduce the load on the healthcare system, especially noting that there are certain resources that are limited within the healthcare system. So we would like to use those upper cells rather than putting too much strain on the lower facilities. Then the age cohort is another perspective that is important, looking at pregnancy and newborn, looking at early childhood, late childhood, adulthood, and of course, the senior citizens. You can organize it by level, and if you look at the handbook, we try and give you the functionalities around this level. Former CEO KMPDC yesterday was talking about changing some of the functionalities of how you categorize the levels. So all the way from level 1 to your tertiary hospitals. Most of the county roles end at, most of the county hospitals up to level 5, level 4, level 5. Just a little bit to talk about self-care, and I think I have highlighted the major things. It's asking ourselves, how can we ensure that individuals have the ability to promote health, prevent disease, maintain health, or cope with illnesses or disability without the support of a healthcare provider. So this is good for both the individual and the health systems, but you need to look at the different interventions that are there and decide which one is best done by the individual, which one is best done by a health worker. So there's need for policy there, and there's guidance, as I say, that has emerged within certain levels, certain areas, and the ministry is continuing to engage in these areas. So in the long term, we will have guidance across all the spectrums of health. So you could be talking about self-management, which is self-medication, self-treatment, self-examination, self-injection, or self-administration of drugs and things like that. You could be talking about self-testing. So can somebody take a samples themselves? Can they self-screen? Can they self-diagnose? Can they self-collect a sample and take to a facility? Can they self-monitor? Or you could be talking about awareness. So that's the spectrum of self-care. The second thing, and I'm trying to just follow this, the apex. The second key area to look at is community health services. And these are an area that is an emphasis to look at. As you realize, the Kenya Kwanza government focuses a lot on this and has given, the manifesto has commitments on this. And because I reviewed all the manifestos, even Azimio, by the way, had this. So if you don't agree don't tell me anything, because even Azimio had a strong component of primary health care. But the Kenya Kwanza government has a strong component of community health services. And currently we have a gap, a slight gap in community health workforce. The coverage of community health volunteers is not as low as a lot of margin. Around 97%, 94% of areas are covered by CHVs. We have about 34% covered by CHAS. But the question is more on the CHV having, so one is of course matching that to 100%. And by 100% here, I mean the minimum coverage, where one CU is covered by at least 10 community health volunteers. But the key issues here, apart from that, is also facilitation of those people within those units to work. So you might have community health units with community health volunteers, but the question is, are they working? Are they facilitated? Do they have basic tools to work? Do they have basic trainings to work? Have they been, if they were trained some years ago, have they been refreshed so that they are up to date in terms of providing their services well? Do they report? Those are areas that we have major gaps when it comes to the community health strategy, and you might need to look at it. So we are starting at the person with self-care, and then we are moving to the community system, which is with the community health strategy. Currently, a policy recommends us to have primary health networks, care networks, and this again is not organized well is not organized within many counties. Most counties haven't adopted this. We have a few counties that have already moved this way. You'll find 1 or 2 sub-counties. And this is basically having community units linked to a primary facility and then a hub, so that you have each community unit is linked to a facility, which happens even now, and then they are linked to a hub. But what is lacking a lot is having a multidisciplinary team which is available to address, allocated to each community unit, so that you can actually have health workers who are working in a team accessible to a community unit and to a community health worker. A lot of counties haven't done that yet, and it's one thing that we continue to advise. Thank you. There's a whole policy guidelines on primary healthcare networks, so I won't go into details in terms of how they are organized. Then you have your facilities, the level 2, the dispensaries, the health center, the sub-county hospitals, the county referral hospitals. And of course, all facilities are expected to provide emergency health services. We've had discussions around certain facilities in terms of funding those emergency health services, and recommendations, I think, in previous forums. So that's one area that you might want to look. But also just noting that all facilities have a role, whether they are public, private, faith-based, they all have a role. Yeah, so the discussion there, of course, is can dispensaries, can health centers help decongest higher level facilities? So the common logic is that if you do your self-care well, if you do your primary care well, then somebody will end up in lower level facilities. And if those are well equipped and working well, then you should reduce people who get into the higher level facilities. Of course, we do have a challenge in terms of referral systems in this country. You sometimes have somebody moving directly from the community with a headache into a national referral hospital. So it's not uncommon to find in KNH's emergency and accidents section, or MTRH, somebody who has self-referred themselves right from. And sometimes what happens is that when you have too much of that, then you deny time and other resources to other people who actually then need those services. So ensuring optimal operation of the lowest level services will help people build confidence in those lower level services and facilities, and therefore go there and decongest your higher level facility. Then you have the whole debate around facility autonomy, where we are talking about facility having boards. We are talking about the facility improvement fund debate that we had. And also there's been quite some debate around where does NHIF reimburse, and does the reimbursement from a local facility, do they, if they get a reimbursement, does it have any impact on them as a local facility, or this disappears within the broader county mechanism? So the second part of this is more about the county health department roles, the different people, and I will not go through this in detail, but I'll just highlight some of the key things. Of course, you yourselves, as members of the County Executive Committee, Article 179 of the Constitution, and giving you, establishing the committee, and then also 183, noting the functions of the CECs. We have the chief officer also, mainly around the County Government Act, Section 45, which provides for the appointment, but also the PFM Act 148, 149, which designates them as accounting officers. And yeah, and their functions there. If you look at your manual, we have actually highlighted what functions and gathered for you the different functions from the different acts of Parliament. Then you have the county directors of the Health Act, and also the functions of the county directors provided there. Also, just to note, the county health management team and their roles, and the sub-county health management teams and their roles. This is provided within the manual. So if you look at the section on health governance, you'll be able to see these roles highlighted. So instead of running through the different acts, that summarizes, we've brought them all together in one place. Just a note around research and evaluation. Of course, both levels of government have a role in this. Karibu PS. Yeah. But we have been having at the county level sometimes researchers, and when we interact with researchers at the council, this has been a question that when we go to the county and we want to do a research, what do we do? Of course, I know that there's a research committee that is established under the Health Act, appointed by the CES. If you look at the membership, that's one of the bodies that is deficient of counties. So you'll see different researchers acknowledged, but there's a deficiency of representation from counties. But never to say we have NACOSTI and ERCs, which have some role in terms of licensing and ethical approval. So the question has been, what exactly is the role of county governments? Who gives the final go? When I want to do research in Mombasa County, who should I go to? Where do I start? And what approvals do I get? Are they administrative approvals? Are they ethical approvals? Are they other types of approvals? What's the difference between program evaluation and research? And is the expectation, the threshold in terms of ethics, is it the same? If I'm doing program evaluation, do I need to have the same documentation as research. So all this basically call for us to think through this function and organize it so that when researchers come, because we, as the Council of Governors continue to advocate for more research, operational research, to guide some of what we are doing, so that when people come, basically they have direction. So on this specific one, I'm not picking a position. I'm not saying that we should do it this way or this way, but it's very important that we have a clear function, place, some clear pathway within counties that then when researchers come, they can follow. So that basically has, and I think when you look at it, you actually see some level of gap in terms of policy guidance that we also need to look at and provide some guidance. Then of course there's the other aspect around how do we build our learning agenda and our research agenda. Do we wait until people come to us, then we say, well, you have come to study the leg, but my research agenda is the hand. So how do we consolidate ourselves as counties, understand our research needs, and share with agencies that are traditionally known to focus on research so that we can bias some of their interests in the first place, rather than be reactive and only respond when somebody gets to you and you think that this is not really appropriate. So these are discussions that we need to have, and I do hope that the caucus will pick up some of these things even as we move forward. Yeah, of course the other important area is to look at the Ministry of Health and coordination with the Ministry of Health. Mutaha will be talking about the intergovernmental relations, but just to note that the Ministry of Health has a health policy, regulation, national referral hospitals, and capacity building and TA role. We currently have one ministry but 2 state departments that helps the ministry to deliver this, but we also have a number of other agencies within the Ministry of Health that exist, that are important to us as counties: KEMSA, the NHIF, KMTC. A number of counties have worked with the KMTC, especially where they had gaps with mid-level health professionals, to fill in that gap. And I think there are actually stories that you can hear about counties that had a gap in maintaining certain cadres, but working very closely with KMTC have been able to fill in there. Then of course KEMRI for research, and there are other agencies. Next. We have national referral hospitals, and some of them have satellite hospitals. For example, the Mwai Kibaki Hospital and this KUTRH satellite in Othaya. And the key things I want to talk about here is the need to keep in touch with these hospitals in terms of a patient referral, to have a smooth referral pathway, but also opportunity for technical assistance and capacity building within the counties. Sometimes some of the referrals that go to this level hospital, for example, I've seen you could be referring, let's say, somebody to KNH, but the specific clinic that you are referring that person to happens on Wednesday. So you refer that person and they get there on Thursday, and they have to stay all the week or come back. So, and probably they are unaccompanied. So if you are doing good collaboration and coordination between yourselves and that, then we should have some of those things harmonized. So especially around referral, that's a major opportunity. It will save the patients a lot of pain, but also the TA and opportunity for capacity. Then we have The regulation bit, the regulation and oversight on the professional side. Kenya Health Professional Oversight Authority, which more regulates and guides the regulators and deals with disputes between regulators. And then the specific regulators, just to note that not all health worker cadres are regulated. I think we have 20-something cadres. Of that, around 11 are regulated, if I'm not wrong. And KHPOA is working to have the unregulated professionals regulated. But even as we say that, most of the major health cadres are regulated already. So, and these are just but a few of the bodies that regulate them. Then finally, just to point out the need for coordination with other sectors, that a lot of time when you're talking about health, we basically are receivers of things that are happening in other sectors. If you talk about education, of course, it's a platform where you can reach children, where you can catapult to parents and things like that. But there are other more direct things. For example, we know that the level of the mother, the education level of the mother is directly associated with the survival of the baby they have. So education, much as it doesn't sound directly health, is a sector that we are very interested in. And so is agriculture, water and sanitation, environment, energy, and other sectors. So it calls for us, both at county level and at national level, to coordinate very closely with these sectors so that we can basically reap the benefits and sustain some of the things that we have made. Because some of the reversals of the gains we have made might actually come from sectors outside health. Yeah, I'd like to stop there and welcome Professor Mutaha Kangu to take us to the next session around intergovernmental relations. But as he comes, just to show the path there, that sometimes when we are building systems, when you're looking at about a health system, you tend to look at something that you want, but you need to think about, is this what people want? Will communities use and enjoy what you have? So thank you very much. This is a continuation of this section, as I said. So yeah, so Professor will take it up from there. Thank you.
Thank you very much. I think those managing, you can put the presentation. You don't have it, the presentation on partnership coordination and intergovernmental relations. Now, fine, I need to start talking about partnerships, coordination, and intergovernmental relations. And I start at a point where Dr. Wamalu pointed out that under our constitutional arrangement, the primary responsibility of providing health services falls on government. And when I talk about government, I mean government under the devolved system of government, which comprises 48 governments. the national government and 47 county governments. Now, that is where the primary responsibility falls. But Dr. Wamalwa also pointed out and emphasized that we cannot be blind to the fact that there are very many non-state actors who play a complementary role in the delivery of health services. And he mentioned clearly that among those non-state actors are the development partners, the private sector, the faith-based organizations, NGOs, CBOs. They all play an important role in delivery of health services. And that therefore means that as you seek to understand the governance of health service delivery, the organization of health service delivery, you need to be clear on the role of intergovernmental relations, especially because we have said we now talk about 48 governments and not just one government. And so useful and effective intergovernmental relations between the national government and the county governments is very critical to the effective delivery of health services. And I am very, very happy that I have to speak about these things with the PS with us here, because I would really like her to carry this message, because a lot of times we have been misunderstood. And in the process, we are failing the Kenyans in terms of delivery of health services. I really don't know what is happening. Is Walter there? I thought I shared the presentation. Now, beyond intergovernmental relations, therefore, we will also need to understand partnerships and coordination. How do we, as the 48 governments, interact with each other and at the same time coordinate with the partners and non-state actors whom we have said play an important role? So we need to understand that. And number three, we will need to understand what are some of the key intergovernmental institutions and structures in our governance system and in our constitutional arrangement. Some provided for by the Constitution and others provided for by legislation. And of course, at that point, when we conceived this program, we had said that before we come to sector-specific induction, you would have gone through a general induction that will give you a clear picture on intergovernmental relations generally before you zero in onto intergovernmental relations in the health sector. So I will speak a bit on the intergovernmental relations generally before I go to the health sector intergovernmental structures and institutions. And number four, we will need to be able to understand the IGR structures, the intergovernmental structures, relation structures established under the Intergovernmental Relations Act, and those that may have been established under other legislations, and in this case, under the Health Act. How they differ and how they ought to work together so that we get things working well. And number five, we will then now go to partnerships and coordination institutions and structures. And again, ask ourselves questions. How do they link up with the intergovernmental relations? What are the intergovernmental relations structures supposed to do, and what are the partnerships and coordination structures supposed to do? And we'll be emphasizing that while intergovernmental relations structures are decision-making structures, because they are structures through which the governments can negotiate and agree on certain decisions, the partnership and coordination structures will have to be looked at as advisory to the government structures. Because I've said the primary responsibility falls on government to make decisions on health, but of course when making those decisions, they ought to draw from the wisdom of the non-state actors. So the partnership and coordination structures are advisory to government structures, which then should negotiate and make decisions to take the country forward. And final, of course, we will need to then ask ourselves, when non-state actors participate in meetings of intergovernmental structures, what is their role there, and how do we manage that? So those are important things. And so starting with the intergovernmental relations, we need to bear in mind that the experience we have had in the past 9 years clearly discloses to us that an effectively working system of intergovernmental relations will be critical in making devolution work for the Kenyans in the next 5 years, especially in the health sector. And if we were to be asked to mention some areas in which we have performed poorly in the past 9 years, I would be able to say intergovernmental relations is where we have not done well. And we need to sit down, understand it very well, make it work if health is going to be delivered effectively to the Kenyan citizens. And we should bear in mind that intergovernmental relations constitute one of the key structural features of a federal or devolved system of government. And therefore, they are defined as interactions between and among governments within a non-centralized system. So our devolved system is a non-centralized system that creates 48 governments, and those governments must interact to make things work. And their relations are necessary because in a federal or devolved system of government, the system combines self-rule with shared rule. So self-rule at the county level. Each county sits and determines its own health issues within the framework of functional assignment under the Constitution. But there are issues of health which will require combined rule, shared rule between the counties and the national government. So that when we say national government is supposed to develop policy for health, that is shared rule, because national government is not developing policy that it will itself use. It is developing policy that is going to be used by county governments to deliver health services. And therefore, you clearly see that to effectively develop policy that will deliver health services, we must exercise shared rule. National government must sit with county governments and say, this is the appropriate policy to govern this particular area. But of course, we need to note that inherent in this system of self-rule and shared rule are natural tensions, conflicts, and threats, which then require to be managed. And you have witnessed yourselves in the past 9 years, those tensions between national and county government, the conflicts, the threats. We need to recognize them, but then say, can we manage them? They are inherent in the system, but can we manage them for the sake of effective health delivery? And therefore, intergovernmental relations come in as that mechanism that should be used in managing those tensions, conflicts, and threats to ensure that we deliver services. And the nature of intergovernmental relations is that our own constitution envisages relations that take a variety of forms, structures, and processes through which different levels of government should coordinate and cooperate in performance of functions and exercise of powers. And this variety will give you, number one, vertical relations, vertical interactions between two or more levels of government. And in our system, these are realized at the national level between the national government and the 47 counties or a number of counties. And number two, this can also be realized at the individual county between the county government officials and the national government officials in the county. Yesterday, when the CEO for population was speaking, he mentioned that when you are doing your planning, you may need to engage with his officers in the counties to give you certain data that can help you to plan. That is intergovernmental relations within the county. You can be able in each one of your counties to say officials of the county government should be able to sit down with officials of the national government in the county to discuss how you want health delivered to the residents of the county, because both governments are serving those residents. But of course, there is the variety of horizontal interactions among governments and which are in the same level, and a good example here are the interactions among the 47 counties through the Council of Governors. We can be able to look at the forum we are having today as a forum for intergovernmental relations to kind of among counties share information, share knowledge, so that when we start delivering services as health executive officers, we are speaking from the same level of knowledge, and the citizens across the country therefore do not get services that are confused because the CECs do not have common knowledge of what is supposed to be done. So at the horizontal level, the counties, the 47 of them, can engage in intergovernmental relations, but we can also have horizontal intergovernmental relations among a group of counties. They don't have to be the 47 of them. It could be a small group, and some of the partners who were speaking before you yesterday, you saw those who say they are having their programs in just a number of counties. Those counties could sit together to exchange ideas about that particular program that the development partner may be implementing in those counties. And that sitting together will discuss some common issues, maybe resolve some disputes and all that. Those are intergovernmental relations. They are horizontal. They help to deliver health services. And then, of course, we do have formal interactions in the sense that they are interactions provided for and structured by the Constitution or by legislation. And there are several which have been provided for in the Constitution and by legislation. But we can also have informal intergovernmental relations. Something arises and it doesn't have to go to a specific structure and a quick committee is formed and so on. That is informal, but you recognize we need to sit together and resolve this problem and so on. Other informal structures may begin, and when they have developed some good practices, legislation may come in to recognize them. And we have quite a number that have already arisen. But there are also situations you can combine formal and informal relations. And these relations could be at the executive level where you belong, they could be at the legislative level, and they could also be at the judicial level. The judiciary plays a major role in resolving intergovernmental disputes. But even as at the executive level, as members of the executive, you will need to know that for you to effectively deliver services as executive, there are times you will need to engage with the legislative arm, both at the national and at the county level. Yesterday we emphasized that a lot of the policy decisions you will take will need to be approved by the county assembly. And so in addition to intergovernmental relations, you have to do some intra-governmental relations with the legislative arm to be able to deliver. Now, the modalities of these relations, although I have pointed out that inherent in a devolved system are natural conflicts, tensions, and threats, a country can choose what kind of modalities. And those modalities could be cooperative in nature, and these are relations that exhibit cooperative institutions and processes, such as consultation, collaboration, co-decision making, coordination, and Americans talk about co-creation. If you choose that you want to have cooperative relations, you start moving away from conflict and say, let us work together. Some decisions, let us make them together. Some institutions, let us co-create them so that we avoid conflicts. But of course, this is opposed to competitive relations, relations that are competitive in nature. And these ones exhibit conflictual processes such as tension, collusion, competition, control, and sometimes even coercion. They are all unnecessary. They create a toxic environment within which we can't deliver services. And so, as a country, we settled for the first option. And that is why Article 6 of our Constitution, Article 2, makes it very clear that we settled for a cooperative system of intergovernmental relations, and this Article 6 is elaborated upon by Article 189, which establishes the obligations of cooperative devolved government. We settled on avoiding conflict and working together. And so I would end conflicts because the MOH wants to just wake up and make decisions without seeking to consult the county government. And we end up with costly conflicts, a lot of toxic relations which actually interfere with the decision making and delivery of services. But what I know is that if we worked together, and you know the beauty of intergovernmental relations is that in the process of developing something together, you educate each other. You clarify misconceptions in your mind. Sometimes the county governments will be able to learn things from the national government and realize, yeah, this makes sense. Other times, national government will listen and say, yeah, we had not looked at this perspective that is coming from the county government. And at the end of the day, when the decision is made, it is a decision that everybody understands, everybody has owned, and implementation becomes very easy. And so we need to bear that in mind. And in addition to the Constitution, we have the Intergovernmental Relations Act, which establishes some intergovernmental structures. We have the Public Finance Management Act, which also establishes other structures. Even the Police Act, even the County Government Act also establish other structures that we need to understand. But what makes relations necessary? Number one is the manner in which the Constitution assigns functions. I've already mentioned that, for example, national government develops policy, but that policy is to be used by county governments. And that therefore makes it necessary that the two work together to be able to adopt a policy that will serve them. Because if a national government makes a policy alone, and yesterday someone asked, can county governments ignore a policy made by the national government? And I said, it's not the best thing to do. But in the past, that is what has happened. Because if a policy is made away from you, and it comes and you start saying, did these people understand what our problem on the ground is? If they had understood, they wouldn't have given us a policy like this. Then you put it aside and continue doing your things. But if you talk to them, they will tell you before you adopt the policy, this will not work. What will work is this. Add in this, tweak here that way, and a policy comes that will make people work. In the past, we have had a lot of problems on that, and I hope we will be able to rethink. Then, of course, there is the issue of functional interdependence. And this PS I would like to emphasize. A lot of people in national government wake up and say, this function is not devolved, therefore have nothing to do with the county governments. Intergovernmental relations are only for devolved functions. But yesterday you had the CEO for population telling you how population planning will be useful when county governments are planning. People in population may think population is not devolved, so why do we talk to counties? Now, sometimes early this year, we were talking to the CECs of health and telling them the NHIF law has been amended and NHIF is now compulsory, and go and mobilize your residents to enroll in NHIF. And a CEC from Pokot told me, but you know what is the problem in our county? Most of our citizens do not have identification cards. And registration of persons is not devolved, isn't it? So you realize that registration of persons is not devolved, but health is devolved, and you want to mobilize people in the county to register for NHIF, but they have no IDs. And registration of persons tells you we have nothing to do with counties. You need to sit down with them in the county and tell them, look, help us to mobilize our people to register in NHIF. Why are you delaying with ID cards and so on? So there are a lot of sectors that look like they were not devolved, but they have an impact on how devolved sectors are being discharged. Issues like foreign affairs, like I remember when the issues of the UK recruitment of nurses from Kenya came up, and the Cuban doctors issue came up. I know that MOH itself protested and said, why did foreign affairs go to negotiate for recruitment of these nurses without involving us, and we are the Ministry of Health? That is how the counties also feel when decisions are made and they are left out. So we need to realize that functional interdependency requires that actually all the officials of national government understand the devolution context in which we are delivering various services, and the role they may play, even if their sector is not devolved, the role they may play to facilitate the delivery of devolved functions. And this is something we need to emphasize. And then, of course, arrangements on how finances are shared are another area that requires, that necessitates relations that will enable us to avoid conflicts. Now, statutory intergovernmental structures, there are a number of them under the Intergovernmental Relations Act. An important one is the National and County Government Coordinating Summit. a very, very critical structure which brings together the president and the 47 governors. If the president used this forum carefully and properly, we would avoid a lot of the problems we are facing in devolution. Number two, we have the Intergovernmental Relations Technical Committee, which serves as a secretariat to the summit, and it is also given responsibility to resolve disputes among governments, and it also took over the functions from the Transition Authority of Transfer of Functions. And right now, you remember the president, on the day he was sworn in, stated that all outstanding devolved functions should be transferred to county governments. And the IGRTC has already started a process, and I want to emphasize that this is an opportunity for us to relook at where we made mistakes in the unbundling and transfer of functions and correct them, particularly in the health sector. Then there is the kinds of governance. There will be more spoken about this by Katra, and you will need to know how to work with it, and so I don't want to go into the details. Then, of course, there is the Intergovernmental Economic and Budget Council, IBEC, which is established under the Public Finance Management Act and is chaired by the Deputy President, a very important structure that can resolve a lot of disputes on finances and which we need to use. And then, of course, there is the Intergovernmental Consultative Forums. If you look at Section 13 of the Intergovernmental Relations Act, says the Cabinet Secretary could establish any sector forums with the officials of the county governments, and they work together. Then, of course, joint committees under Article 189, and then the policing forums authority under the Police Act, and then, of course, the Intergovernmental Forum, which had been initially intended under Section 54. Very, very important structures. Can we now come to the health sector? Now, if you come to the health sector and look at Section 13, subsection 2, you will see that there is provision for establishment of fora. The Cabinet Secretary can establish a forum with the county governments to discuss issues. But if you look at Section 26 of the Health Act, you see that it establishes the Kenyan Health Sector Intergovernmental Consultative Forum. And the question that arises is, does that substitute what Section 13 provides for? If you look at that forum under the Section 26, it is supposed to be for the Director General of Health at the national level and the directors of health in the county governments. But in practice, it has been turned into a forum of the CECs. And my worry is that one day a very useful decision will be made by that structure, and then someone challenges it, and the court will say this was a wrong structure. So we need to rethink this. And my argument would be that a structure that brings in CECs and the minister and all that should be established under Section 13, subsection 2 of the Intergovernmental Relations Act, and then Section 26 we leave it just to the directors, so that we don't create a situation where people will start questioning decisions and take us back when we have made a lot of headway in negotiations. So we need to clarify that and see how it works. And then, of course, beyond that, we also have other structures. Under the Constitution, we have the bicameral parliament, comprising the Senate and the National Assembly, which plays an important role. We have, of course, constitutional commissions and independent offices that also play a role in intergovernmental relations, such as the Commission on Revenue Allocation, the Control of Budget, the Auditor General, the Salaries and Remuneration Commission, the Law Reform Commission, and the Office of the Ombudsman. Offices that you may need to engage from time to time when certain issues arise. So you need to understand how they operate, what their functions are, and how they can come in to help you when issues that relate to them arise. But then we have, under Parliament, we need to mention a few things, because I've said, although it's executive, you will need to engage with the legislature. Parliament, the Senate has a committee on health, which we may need to engage on very many issues, legislations, division of revenue and all that. So there are several issues there that we need to bear in mind. The National Assembly, again, makes very fundamental decisions. And one of my complaints in the past 9 years has been that the National Assembly is one of the institutions that present itself as having nothing to do with the devolution, yet they make fundamental decisions that affect devolution. And we need to start reaching out to them, we need to start engaging them, we need to start educating them to realize the important role they play in devolution, so that we see what to do. And they also have a health committee which we need to engage. Then, of course, at the county level, every county assembly is divided into sector committees, one of them being on health. And this you must take as your most important committee to engage when you want to raise things in the county assembly, because they will become a hindrance if you don't know how to handle them. And so you need to know how to engage them and see what to do. Now, partnership, we do have, before devolution, there was a partnership and coordination framework that had been negotiated between MOH and partners. But after devolution, the situation changed and a new framework had to be negotiated, and was adopted 2018 to 2030. And this one seeks to provide an environment within which the governments that have primary responsibility in health can coordinate with partners and non-state actors to be able to deliver health services. And among the important issues on which this coordination needs to be done are at the level of planning. You need common planning between the county governments and the partners in your county, so that at least their resources are fitting into the plans of the county government if they are going to be useful. Common budgeting is one of the things you'll need to do with the partners. Common funding is something to look at. Common monitoring and evaluation is an important thing you need to do with the partners who are working in the counties. Common management arrangements, which are based on country systems for channeling funds, you need to understand that. And then, of course, the Public Management Act comes in, and you need to look at that. Now, because of that partnership coordination framework, we have this structure, which has also created, the framework has also created some structures. We have the Health Sector Advisory and Oversight Committee, which brings together government officials and partner non-state actors there. Then we do have the Health Sector Interagency Steering Committee, again bringing together government officials and partners. And then, of course, we do have a secretariat there, and on the other side you have government. And then down there are interagency coordination committees, which are organized along thematic areas, and a lot of CECs will find themselves working in these thematic committees to generate ideas together with the non-state actors that will eventually inform certain plans, certain budgets, and all that. And so you need to look at them and be clear where your expertise will be most required and will make a good contribution, and so on. And so that advisory committee is chaired by the Cabinet Secretary for Health and co-chaired by the Chair of the Council of Governors, and the Council of Governors Health Committee and of course the chair of the Development Partners Health Kenya, and then of course it provides oversight and direction in the development of key strategic interventions and policy decisions in the health sector, and it meets twice a year, and other members are stated there. You'll get the document and look at it. An important structure where the stakeholders who are not part of government contribute to the development of some of the policies and decisions that will take health forward. Then we do have health sector interagency steering committee. This one brings together representatives of the key sector partners to provide technical level strategic leadership and direction, and promotes technical support and dialogue on strategic sector between government, donors, FBOs, NGOs, and civil society, so that you do not have the civil society and CBOs in your county complaining that they don't know what is going on. And so these are important structures. You need to look at that framework and understand it so that you know how you fit in. And then, of course, we do have interagency coordinating committees, which I talked about, where the thematic areas you may be members in some of them. You can see the thematic areas set out there. And then, of course, we need to know some of the important non-state actors, and in terms of development partners, we have many who play a role, and the US government has actually been very central in supporting a lot of health activities. And you need to know that it has very many agencies that work in health, and you need to know them. A lot of times they use acronyms, and you may not know what those acronyms mean. You first have the USAID, which does a lot in prevention, care, and treatment of AIDS and HIV, tuberculosis, and all that. Yeah, okay. Now I'm finishing. Then we do have CDC, which is a Center for Disease Control. We have PEPFAR. A lot of times people wonder what that means. You can now see the full name there. And they all have a lot of activities in the counties, and you need to work with them. But of course, we have others like the World Bank, the Global Fund. We have the British FCDO. We have the NGOs like HENET, which play a role in health. We do have agencies like JICA, we have DANIDA, we have the German GIZ, we do have Bill and Belinda Gates. All these are partners that are supporting health a great deal, and you need to know how to reach them and engage them. And then, of course, we do have even UN agencies that deal in health. A long list of them is set out there. You will need to look at it and see how to engage them, and then see how they help you in health. Thank you so much.
Another round of applause for Dr. Mutaha. Ladies and gentlemen, I think those two presentations have really brought to focus key things that we really need to think about from both contextual point of view, from a partnership point of view, and how we govern health. So at this point, I'll ask Katra Ali to come give her presentation so that we use that to start engagement in terms of discussions on this topical area. A round of applause for Katra, please.
Thank you very much, Regina. I think we need to stretch because I want people to concentrate in my presentation. So, tusimame kidogo. You know, adult can concentrate for only 2 hours if they really want to concentrate. The rest, like, you try to absorb. And we are giving you a lot and heavy information. So, what are we going to do? We are going to jump. Just go behind your chair. Be ready to jump. If you don't jump, you will come here, so that you will you'll do my presentation. Nyama, nyama, nyama. Hey, I'm going to bring people here so that they dance for us. Nyama, nyama, nyama. Nyama, nyama, nyama. Guama, ruka, ruka. Nikisema nyama, 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 unafaa kuwa pale kwa mahewa. Nyama, nyama, nyama. Nyama, nyama, nyama. Nyama ya mbuzi. Nyama ya kuku. Prof anaruka na mkono. Nyama ya mbuzi. Nyama ya kuku. Nyama ya panya. Si tunakula? Nyama, nyama, nyama. Nyama ya samaki. Nyama ya kuku. Ya punda. Guama. Tunakula. Nyama, nyama, nyama. Nyama, nyama, nyama. Nyama, nyama, nyama. Prawns. Asanteni. Niliona watu wengine wakikataa octopus wanasema inakaa hivi. It is very sweet. You'll find all sort of seafood. So when you see octopus nini, you already know how it looks like. So unasema ai hii sikuli. Thank you very much. I'll quickly take you through the Council of Governors Health Committee. I know yesterday we had a lot of session, and most of what I'm about to say was already done by the chair of Health Committee, but it's very important for the CEC's health seated here to really understand what is the role of COG Health Committee. This presentation, part of it is already in the manual. For those of you who may be managed to go through the abridged version, you already have this. So just get to look at it. So I will jump some of the things because we've already looked at it yesterday. But the outline of presentation is on objective, session presentation, and then we have a quick plenary. But in the to outline the organization, roles, and function of the COG Health Committee. COG Health Committee are the governors of the Health Committee, supported by the Secretariat. Discuss the role of COG Health Committee as a health intergovernmental coordination platform, and then highlight the key roles. Just a quick background. The mandate of COG is basically to consult amongst the county governments, sharing of information on the performance of the counties. When they are actually in the forum, they mingle a lot. What is it that we are doing? So they share a lot of information among themselves so that they can also improve on maybe that area in their county. Facilitating capacity building for governance. And the COG basically is an nonpartisan organization established under Section 19 of the Intergovernmental Relations Act of 2012. It's important for you to know. And the COG therefore plays a coordinating and facilitative role among the 47 county governments on all matters of policy, legislation, capacity building, administration, actions, general sector development in the counties. We align ourselves to our COG strategic plan 2022-2027. Ours expired in June, the one that expired in 22. So this is a new strategic plan. Very important for you also to know that we have pillars in the strategic plan on knowledge management, learning and innovation. You are going to have a presentation, maybe also from one of my colleagues taking you through this. Stakeholders engagement and resource mobilization. We are already doing it. We are here courtesy of our stakeholders and partners. Cooperative devolved governance and intergovernmental relation. Institutional capacity building, COG and county government. The other item is policy and legal environment. So in your bag, you can also find another booklet that we developed, high level, in a very high level meeting on policy and legislation barriers. So that is also one of our mandates. We have committee members of the council. Like we have 18 committees at the Council of Governors. So each committee is chaired by the chair or by a chair, and they have a deputy. So any governor will actually request to be part of those committees as members. So you can be in 2 committees or you can be in 3 committees. And the COG Health Committee actually attracted more governors. Today I'm going to take you through the members of the Health Committee, but in the next forum, maybe when we are going to have our quarterly meeting, I'll close it and then I'll be asking you who is the chair of Health Committee. So it's important to concentrate on this. We have Mudhomi Njoki, who is Tharaka Nithi governor, as a chairperson. He was here yesterday when he was doing the opening remarks, deputized by Gladys Wanga of Homa Bay, vice chair. Is Waziri here? Waziri Homa Bay. Okay, Gladys Wanga is the vice chair. So unaona hapo kuna gender. Then the vice chair of the Council of Governors, FCPA, Ahmed Abdullahi from Wajir, who is deputizing Waiguru, is also a member. George Natembea from Trans Nzoia. Moses Badilisha Nyandarua. Professor Nyang'nyong Kisumu. Tichilo Vihiga. Irungu Kangata. Muranga. Mohamed Mahmoud Marsabit. Susan Kihika from Nakuru. Mohamed Aden Khalil from Mandera. Risli Rotech Elgeyo Marakwet, and Mutahi Kahiga from Nyeri. We have 15. There are others also who have shown interest, so we are not going to lock them out. If they come up, they sat in that meeting up to 7:30 p.m. So anytime they are well versed, like, because they have a forum and I'm the secretary to their forum, we share a lot of information as the way we share with you. So when we post something on the wall, read. If you don't read, he will read ahead of you and he will ask you. So if your chair is among the members of the health committee, they have a platform. Please. Si unajua Gregory? Gregory knows because his governor was my chair. So anytime when he's asked something, those that he cannot be able, he asks, Katra na hiyo namwambia. So we'll be sharing everything that we'll be sharing on their forum in your forum. So not only them, I know the chair is also very vibrant. Most of this information he also shares on the 47 governors wall. So lazima mukue antenna ikue up. Health committee, just go back. Health committee considers all matters relating to the health at the Council of Governors, and it looks at the institutional structures and related law framework policies and programs on health. The committee functions through a international level to realize optimal health service delivery at the backdrop of devolved system of governance. Anything to do with health. When you see something on papers, be ready. If it is something to do with health, the governors will ask you. We always give them updates on the papers. We post all the papers, headlines, anything that touches on county, anything, so they know. So ukiona papers, ukiletewa asubuhi papers kwa ofisi, angalia tu section yako health. Is there anything on health? It's very, very important. I'm just giving you that information because your committee members, if you have a member there, you have to be well informed all the time. What are the TOR for the Health Committee? A developed framework to guide and assist county government in establishment of institutional structure for the management of health, coordinate intra and interagency and government consultation on health sector issues, including existing and evolving health policies, legislation, regulations. We are very keen. Any policy or any legislation or anything that close back health, we are on it. Like we always say, this is the function of devolved government. And I say, even if you may not grasp everything, it will tell you what is the function of the national government, what is the functions of the county government. So, and you have the capacity. That is why the constitution devolved health. You have the capacity, you can deliver. Don't say, you know this one, we don't have the capacity. Now you are challenging the constitution. So anything that close back health, it is our role. We have to have our antennas up, coordinate and harmonize COG views and perspective on health matters. This one we do very closely with the CECs, the technical officers. I remember engaging the CECs, like there is this thing, we are working on this. Kindly let us quickly convene and work on this thing. So when we ask you, please, there are some things that are very urgent. Don't say, hatuna time. If you don't have time, we may do it, but we will say in consultation with the CECs held. At any one time, the caucus leadership you've had, you'll be having very with the committee members. So if we are unable to get the 47, we will be dealing with the chair. And if you are sent something, you quickly need to look at it. You don't need to do it yourself, but you have technical officers who can basically give us that information so that we consolidate and we say this is the position of the county government. So as secretariats, we don't work alone, we work with you, the CEC. So give us also your time. Create forum for sharing emerging issues and best practices, including modalities. I know Walter is going to talk on that. I don't need to preempt it. Provide platform to share ideas on how the lessons from past health challenges can inform future proactive health management strategies and solutions. And that's why I said, you are the new CCMs. Something was already going on at the county. So tap on it. Pick from where they have left. If there is anything that you feel you need to do differently, do it differently. But pick up from where the others have left. So don't start everything new. Provide platform to review and mainstreaming of ongoing health programs within respective county. That one we are also going to take you through a deep dive of the programs that are running within the 47 county. But I know CIDP already something is ongoing in counties. Provide a forum for harmonization of plan, regional and national-wide health interventions by various stakeholders, including ideas of how counties correspond to health needs. We also coordinate county research and analytics studies on key areas of health issues. There are a lot of information at the counties, a lot of information. Please try to convert that information into research. For example, if you realize that your workload or the data in the health facilities are showing that you're having so many cases of hypertension, it's very important for you to know why is this thing emerging? Why do I have this? Where is the problem? So you can convert those information into research. And I know you have that capacity, and you know you have technical officer who is a research person at the county level. The COG Health Directorate, I know the secretariats are seated here. I will be able to introduce them to you. The COG Health Committee is supported by the secretariat under the CEO, who was supposed to be with us yesterday. Here there is a Directorate of Health Services headed by a director. And it provides secretariat services to the COG Health Committee. Any matters to do with health. Like, we don't wait for them to call us. When we see that there is something emerging or there is something on health, we quickly pick it and then brief the chair. Tell him, Your Excellency, this and this and this is happening, and you provide advisory. So some of these advisories, we work closely with you. So if it is very urgent, we bring on board our legal people and we try to work together and then give them something, at least, because sometimes it is just so quick. They maintain also COG Health Committee position on various issues through keeping briefs, press statements, memoranda, position papers, among other documents. So when you also see pressers, you see word on health, this is the work of the secretariats. We are doing it. And we thank God because whatsoever the information we are giving is very fact, because we get this information from the counties. So we always say the information we have is very factual. We also collect, analyze data information from counties and update the health committee on various health aspects, hold sectoral forums with CEC, chief officers, directors, and share on matters related to the sector. So this is an induction. But starting next year, we'll be having a quarterly meeting. That will be every after 3 months. So we invite you in advance. We may hold it out of the county, but we bring you all together so that we share. And I know maybe by the time we are going to have our first one, there'll be a lot of experiences, a lot of consultation, and maybe there are some things that you really want to consult, but we say at any one time we are very available, you can reach out to us. We attend and participate in various intergovernmental partnership and coordination framework. I know Mutaha has mentioned on the IGR, and that is also where you need to place your position, the technical, thematic technical committees, but I'm going to highlight on that. The committee offers platform for peer consultation, sharing of best practices. We have a Maarifa platform where we gather a lot of information and post it on our Maarifa platform. But I don't want to exhaust that because my colleague is going to work on that. The committee also solicits views from counties through various mechanisms, including caucus meeting, forums, regular ad hoc meetings, letters, as well as other. Sometimes we do letters to you urgently and we tell you there is this, it's an emerging issues. Kindly help us. There are bills, there are things that actually need county participation. So we just pick those and like we give you time frame. If we get even for 10 counties or 8 counties, we pick on them. But we rely so much on you because we want what you are also going to present is the perspective of the county government with their support. The committee also facilitates inter-county meetings, regional blocks or otherwise for consultation on specific issues. I know we have around 8 or 6 regional blocks. LREB is very active. Central is also coming up. So find your space also in those regional block. If maybe you have it in your county as a regional, if it is central, if it is upper eastern and the rest, find out, because there are regional blocks that are very active and they discuss even matters of health. The committee work closely with COG committee, including communication. We have a whole department of communication. We don't hire communication from outside. We have a finance committee, finance internal auditors, human resource committee, legal unit, Maarifa Center. We have a whole legal unit. So if there is anything to do with legal matters, unless otherwise, our legal officers have the capacity and they actually represent the council in any forum of legal. So we also have procurement, just like the way you counties also have procurement departments at the county level. Next. So some directorate engagement forum. I've already said about the quarterly meetings. We also have something called devolution conference. Wangapi wamesikia? Devolution conference. Just raise your hand up. Okay. So our other devolution, our biannual, initially it used to happen annually, but now it's going to be biannual. So our next devolution conference will be next year. So we'll be engaging you, participate also in that forum. Participate in the forum. Just the way I said, we have committees. All the committees will be having their sub-themes. They'll be having their panelists. We'll be having our positions. So you have to participate to actually. I know those who have been previously, before you have been participating in devolution conference. Instead, devolution of address, which actually happens on annual basis. It is actually done by the chair of the council. Like now, even if you Google, you will be able to find state devolution address of last year. So it's very important for you to know, because like it touches on all sectors. For example, if it is on health, in the year maybe 2022, you address the issue of HRH. How was it? In terms of infrastructure, where were we and where are we now? So it is done annually, and the committees actually feed into the state of devolution address. Once it is consolidated, it is actually endorsed, and that is what is actually released to the media. We have a COG annual statutory report, annual work plan, just the way you have, reports of committee on achievement. This is actually one of our achievements, and we are going to put it as part of our report. I know once we compile that report, we can also be able to share with you because it is your report. Quarterly meetings for governors, CEC Health, Chief Officers of Health, CDH. There is something that we discuss on this, I know. Like, what was realized and what really came out is like, people don't talk to each other. I remember there is a time we formed a joint CECs and health and CEC finance. And I remember one of the CEC telling me, I know she's also here, that this is the first time she's sitting with her CEC finance. CEC finance are called super CECs at the counties. So we don't want to have super CECs in health that don't talk to chief officers of health. The chief officers are not talking to the directors. This time round, I know after the caucus election, we are going to do things differently and see how we can be able, because the interest here is health. How can we improve on health? How can we talk together? How can we be able to work together? There is no, like we have roles, everybody has his roles, but you cannot even as CEC achieve alone without liaising with the director. You cannot achieve alone if you're not talking to your chief officer, because remember, they are the accounting officer. They'll sabotage you. So we need to actually strengthen some of this and see how we can be able to harmonize your working together. Weekly coordination meeting, health intergovernmental sector forum, meetings of health coordination committee. This is something that we need to talk about. The ICC, interagency coordination committee, technical working group. There are very many. Sometimes we just approach some of you and say, please, there is this. Nominate yourself. In our forum, so we said, who is going to be here, who is going to be here. Nyinyi wenyewe mnachaguana and you give us the names. Media monitoring, bills, gazette trackers, reports, I said it's very important for you as a CEC at that level to be able to know. Read the press statements of the council, of the chair of the council. Always read. You are the CEC, read. Have information. Information, we say, is always power. In terms of organization of the CEC members, chief officers, directors for health, from all the 47 county governments come together in a forum, provide technical guidance, direction, advisory. to the COG Health Committee on all matters pertaining to service delivery in the county. Sometimes we just call you and tell you, please, we need this information. And when we tell you, please, we need this information from the challenges we have, give us the information on time. Governors don't wait. If they say, I need it now, you have no excuse. If your governor calls you and tell you, I need this, you cannot tell him, I'm going to refer. That is not in their vocabulary. If they want it now, you give it now. Historia kusema sijui hakuna, it is not in their vocabulary. I'm just giving you hints. Because if like your governor calls you and tell you, there's this, I saw it on paper. Do you have any idea? Let me ask my director. See, amepoteza confidence na wewe. So always have first-hand information, first-hand information. If the governors ask you something, have first-hand information. And information, I said, is power. Even if you don't know something, don't pretend that you don't know. You can quickly, you know, tell him something, and then you may just do it in a clever way, but give him the information. The health caucus are led by following elected members. I know we are going to have election in the last few days. We have the chairperson, we have the secretary, and we have the deputy chairperson. So as we are doing this, we always say, let us also consider the gender. But what is the role of the subcommittee, the technical committees? I know when we are having in IGF, we usually have thematic committees on building blocks of health. These committees actually provide guidance to all matters that brought the attention to the subcommittee. This presentation is actually in your forum. Please just check. Let me just go to the next slide. Thematic technical committees and their scopes. All members of CCMs, Chief Officer Directors, caucuses join and participate in thematic technical subcommittee based on their competencies and in their interest. You hear yesterday Dr. Yumbia saying, I want to be in the thematic committee of HR. So you need to select yourself in the building blocks and say, this is going to represent us, this is going to, and you have to be very active, very active. So we have somebody like a chair. You'll be chairing and co-chairing with the national government. So they'll have, for example, I know Dr. Sitine, I'm just giving an example. If Dr. Sitine maybe is the chair, then you find somebody co-chairing from council. If the council is the chair, you find somebody co-chairing from the national. So we have them as, we have the thematic committees on human resource, service delivery, quality assurance. Look at this so that before you go, this is also something that we need to assign ourselves. Health product supply chain, if you have an interest, start thinking about it. Health finance, leadership, governance, health information research. This one we want leaders who are going to be representing the 47 counties from these people who are seated here. Kindly just move the slide. I don't need to go into the details, but if you are chairing, for example, human resource, what are the focus? Training of healthcare workers, including specialized training. It is still a problem. We say training is the functions of the national government. How can we be able to give them back to us? So that the way Waziri Eda was yesterday saying, so that we have avenue to recruit others. Universities are producing graduates. So where are we taking these graduates? If only national government take over training and have the postgraduate training and post them as per the need of the counties, counties will have that avenue of actually recruiting. Attraction and retention of staffs, I know Mandera, you are doing that. You may not find somebody who is very interested coming to Mandera as a specialist, but you attract and then you retrain. These are the areas now you need to focus on in terms of HRH. Next. Service delivery, quality assurance and standard. I know our PS also has, she knows this, and these are area. In terms of UHC implementation through PHC approach should be the focus. Kenya quality model for health, accreditation framework, referral strategy implementation, community health services, demand for quality, and the rest. So these presentations are actually in your manuals. Just move the slide. In terms of health financing, you can see the points. I don't need to go through it. Then deliverables, participate in intergovernmental activities. If you hear there is intergovernmental activities, this is a forum that we exchange our ideas. We talk to each other. We see how we can be able to do things differently. Please, if there is this meeting, join. join, diarize, and never miss some of these meetings. It's very important also for you as an individual because you gain a lot of knowledge. Provide periodic reports to COG Health Committee, quarterly, semi-annual reports. Sometimes when we are gathering for example, when we are talking about maternal mortality rate, I know for counties, as much as we have the national figure, you also give us the facility one. How are you? Then we just try to aggregate and see this has actually improved from this to this. So then provide policy position on consideration by the CCMs. You give us a lot of information to advise the governors and advise the COG on thematic issues. Anything that arises from the intergovernmental forums, we actually brief the governors of health committee. Terms of reference, also in your manual, but quickly, you're supposed to be implementing county legislation. Implement within the county national and legislation. Extend to that, it requires manage and coordinate functions of the county administration, prepare proposed legislation, provide the county assembly with full and regular reports on matters. I know some of the things that you also take to the county assembly are shut down. But then, how can you be able to work closely? We are trying to see how we can be able to bring the MCS of the health committee and the CCM's health together so that we have a forum. The slide is not moving, so you will give me bonus because my slide is not moving. Other roles of county executive committee, your role in terms of leadership and governance, planning and budgeting, that is your role. Performance management is your role. Please do performance contracting for your staffs. That is the only way you can hold them accountable. Uwezi sema unaita mtu unampatia show cause letter na hauna hata ile series of event like this person alikuwa anafanya nini. Please, if you want to basically know that you are doing well, have performance contract. You have specialists in your counties who may be, like you have 4 gynecologists who do a lot of local arrangement. One is present this week, the other one is present the other week, the other one is, so you find maybe your consultant, a pediatric consultant, is working only for 1 week in a month. It is you to hold them, you have to hold them accountable. See how you can be able to sit with them and plan. At any one time, these are your staffs. If like they tell you there is no much work, you have sub-counties. They don't necessarily need to go and sit there, but you can be able to organize, take the referral services to the county level. Book patients of gynecologists in that particular sub-county, send them there to have a clinic maybe for 2 days. You can post another one in another sub-county to do the same. Think out of the box and see how you can be able to utilize and maximize these resources. Otherwise, if you don't do that, and I know the governors nowadays, all of them are like, they want to do a lot of ITs and install some things, you know, for you, when you come on duty, you have to clock in. There is a system they are trying to put in. So by the time you are evaluating that system in a month, you find that a staff has been missing for a whole month. So see how, I know you're going to have this forum, see how also you can be able to interact. My sister is standing up. I don't want to take you through the TOR for chief officers. It is in your manuals, you can check. Just next. Terms of reference for county directors of health, jana muliambua fanyeni kazi na watu. These are your technical advisors. So you have very, right now I was hearing there's a lot of reshuffle. Eh? That is why even we said we need to induct also the directors, because you may find a pool of new directors. The other ones have been displaced. So we have no control over that, but we need to actually induct them and see how they can also support them in their areas of expertise. Next. So progress update on delivery of mandate. Key resolutions in county engagement. There is adoption of the model law for health facility. All along in this session, in this workshop, you've been hearing about FIF. So we are preparing for your model law. There are counties that are already doing well. We are incorporating and seeing by end January or February, I know we are going to have a session on this. You will have a model law that is going to be endorsed at the council because it has already have input from all the 47 county governments. And then we see how we can be able to adapt that. Review of county health fiscal space to inform health financing, transition discourse, donor funding may reduce. Prioritize preventive health. It also came out very clearly yesterday. Implementation of logistic management information system so that you don't have stock out, the visibility. Key resolution in county engagement, again, there is need for jointly undertaken, coordinated and comprehensive review of existing health policies and legislation, beginning with KEMSA Act, NHIF Act, There'll be a lot of work around this, and I know it is already ongoing. Improving engagement with other institutions, IGR space, we have to work closely with the national government and also other stakeholders to formulate basically and implement the health policies and legislation. You've heard yesterday what Mutaha has said. There are some policies that have not been reviewed, so even after devolution. So we have heavy tasks, the unbundling and transfer of functions. That is something that is already ongoing. There's a task force I know that is in place. Strengthening emergency preparedness and readiness at county health system. COVID has taught us a lot. COVID has taught us a lot. When COVID struck, we used to sleep in Pan-Afric Hotel, you know, presenting, doing this. The meeting never used to end. People were fatigued. People contracted COVID. So how can we be able to prepare so that we don't run without shoes when the things strike? We kept on saying, iko China, haijafika. The first case, ndio watu walianza kukimbia. So as much as your leaders seated in this forum, kindly ensure that you budget for emergency. Like now I know Waziri Tana River, you have COVID, you have cholera. So what are you doing? Uko na pesa? And there is delayed disbursement of funds. So where do you have money? If you have not planned, you will start running up and down looking for partners to help you, to support you. Conditional extension of managed equipment, I don't want to talk about this. It is at a higher level, just the way the PS said. The CS and the governors are already engaging on this. There is something, conditions that they have agreed upon before the extension. But the extension, the contract for some of the equipments are coming to an end in December, this December. So if you say that you are not extending and you are providing renal services, dialysis, if you don't have plan, watasema the new CC mwenye ameingia, ametoa mashini yote. Hata hakuna kitu anafanya. But this is an engagement. I don't want to deliberate it here. And the others are actually expiring in 2023 March, May. So we need to engage and see maybe how we can be able to improve on that. And then settling of outstanding KEMSA debt, I don't want to repeat. Who are the health committee partners? This is the last slide. So they are already in this room. Please see how you can be able to engage them. There are a lot of resources. Wako na pesa mingi. Mnaona Caroline amekaa huko nyuma. Wairimu wamejificha huko nyuma. Muwatafute, mwambieni tafadhali mtusaidie hii na hii. They have a lot of money. BMFG really wants to work, and now their space actually, I know with the current recent engagement that we had, they want to focus so much on community health. Do something, let them tap on it. So at this juncture, I think this was my last slide. Nimeshukuru sana, asanteni. I know it was so fast, but the slide was heavy. But we say 48 governments and 48 governments and 48 governments and Sarah amesema hivi.
Thank you very much, Katra. And sorry, I was just giving you security. I was not, I was being a good bodyguard. Ladies and gentlemen, I think we have really eaten into a lot of time, and my suggestion is that we have a working tea. So you can pick your tea and still come back into the room rather than break for tea. Is that okay? We have consensus on that? Thank you very much. So before I call in Walter, given that this is a mature class, we have really discussed quite a lot, and I think we really need to have a session where we have an interaction with the CECs. This is a very important topical issue. Health governance is critical. Listening to Dr. Wamalwa, listening to Dr. Mutaha, listening to Katra, you get a sense that the structures are actually in place and they're supposed to be functional, but we still have things to do with threats, tension, conflict, toxic environment that is affecting the way health is governed. So I'd really like to hear some reactions from the audience as relates to health governance, given your role as CECs, which is leadership and governance that encompasses all these other things. So can we then have the Secretariat moving around with the mics so that we get to hear whether there are questions, comments, rebuttals based on the presentations that we had made before I call in Walter to do the Maarifa presentation. I will start from Yumbia's Class, is there anybody from that end who has a question, a comment based on the presentations that were made? Going once, twice, thrice, gone. I move to this group here. Is there anyone with a question, comment? Going once, twice, thrice, gone. I come to this group here. Anybody with a question? Busia, Trans Nzoia. I will just call you by your counties. I hope it's okay, Waziri.
Okay, thank you very much for the opportunity. I was looking forward to hear what the health information and research team does, because that's being a researcher. So I'm looking. My question goes to Dr. Malwa. When you talked about the research policy, the policy on research, because the other day I was in the office and someone came in and told me I'm from this organization and I'm here to do a research at Lupe University. And I didn't quite understand. So I think for me, I actually asked myself, so who gave him the authority to do the research in the hospital? Where is that feedback going to? What learning will we get from? I think there is a lot of confusion. I'm just wondering, how long will this policy take and why is it taking very long? Because I think it's something that we really need to spearhead to make that it's operational. Thank you very much.
Trans Nzoia, Pepela.
Yeah, thank you, Chair, and thank you, Dr. Katra, for the nice presentation. Mine, starting from Dr. Malwa, and also yesterday when Dr. Sheikh was mentioning about the population structure. It's a comment which maybe we need to take up as counties. One is in terms of the population. Because when we look at the population that from the last census and the projections that are coming from the Kenya National Bureau of Statistics, they are not in tandem with our service delivery on the ground, and especially the population for under one, which when we use the systems that we are using in terms of data collection, you will find that our indicators will be over 100% coverages. We have 94% of the communities, functional communities across the counties. So we may need to take a deliberate move of taking the census, because they do household registration using the household register, so that we have the accurate population for us in terms of planning. Otherwise, we shall still be having a challenge in terms of planning if we don't know our population. So in this aspect, it will be important for us to maybe engage the community volunteers, do the household registration, and have our population right. The other component in terms of the partnership and the partnership framework, we are already 2 years down the line since the partnership framework was signed, and we haven't made a deliberate move. I think we need candidly at this time around to operationalize the partnership framework, so that if we say 48 governments and one nation, let's have a deliberate move of having one plan, one monitoring framework, and one financing mechanism.
Thank you, Trans Nzoia. We are still in this group. We had already moved from this side. We are moving that way. So there's a hand right behind there. I think that's CDC. Ruth, you'll go first, then we'll go to CDC.
Good morning, everyone. Mine is just a comment. We do really appreciate the presentations that we have been getting. And as I said yesterday, that this team is very lucky to have had disorientation that we did not. I think devolution is really working when you see the counties having a say in every committee. I think we would like to get is also to sit in the NHIF or the KEMSA board. The reason why I say that is because we are where the rubber meets the road. And when you have representation, what happened the last time when they were making some of the reforms, we had a platform to sit with KEMSA and to sit with Ministry of Health, but the voice of the counties was not really represented the way it should have been. And I will also still repeat again in regards to the devolution piece. I still have a strong feeling that a task force still needs to be reconstituted with our legal department and the COG, where you also have those who have sat in the counties as being a part of that smooth transition of things that have not been completely devolved. That still stands to be an issue. Because if you look at the other task force, it was a group that had not experienced devolution. But now we have people who have actually been in it. They need to have a voice in it. Thank you.
Thank you very much. We will have CDC right behind. Okay, this is the most active row.
Thank you, Chair, and thank you to all the presenters. My question is for Dr. Wamalwa, especially about the national level structures that you had talked about. My question is about the new Kenya National Public Health Institute and what you think the role is for that institute at the national level and how it integrates and coordinates with the counties, and what's the role of the counties for the NPHI work and the functions mandated under the executive order. Thanks.
Thank you so much. I think we have Dr. Ganda.
Yes, thank you very much. I think mine just adds on to what she's talking about. I heard the professor's presentation about joint authorities, Article 189, subsection 2. And I'm wondering if we have any joint authority that has ever been formed since devolution started in this country. And I talk about this in relation to the National Syndemic Body that was formed by the President, which COG, through the governors, have objected, but which most of us CECs actually think it is a very good body, but needs to be a joint authority against being an authority that is one-sided and elected by the national government. Apart from that, I have two other comments. One is about the issues of level 4 facilities. And I think with the advent of PCNs, primary care networks, which are supposed to be linked to be a level 4 hospital, in our experience in Kisumu, one level 4 hospital per sub-county is not enough to be a hub for the PCNs. And that means that you probably will need more level 4 or primary hospitals in the sub-county, so that each ward or 2 wards should have one level 4 facility. The definition of a level 4 facility as per the bodies which we have is so big that it's not really a primary facility. You talk about how many specialists do you have, CT scan, MRI, and so we really need to relook at level 4 facilities in relation to the primary care networks, or have level 4A, 4B. The way I've seen the new levels have been developed for primary facilities. I don't know if they'll apply also to government facilities. And the move actually is to move towards services and not structures. The idea of a level 4 should have 20 acres, I don't know what, plus 200 beds. It's not really valuable. If you go out of the country, you'll find transplants being done in very small hospitals with maybe 15 beds. And so the idea that we must have 200 beds for you to be able to do a kidney transplant actually inhibits growth and makes hospitals more generalized than more specialized. We need also to move towards specialized hospitals, which are smaller but specialized or subspecialized in a certain given aspect. And my third comment is towards community health assistance. I know Dr. Wamalwa talked about having less CHRs, CHARs in our system. In our experience, once you digitize the community health system, then the role of the chair actually becomes much less. And you need to relook at how many chairs do you actually need to supervise CHVs, because the digital platform does it automatically. You can already see what is the performance of a chair, of a CHV who is not performing. You don't need to visit them. So then you might not need the same number of chairs that has been prescribed in the initial document into moving into the future. Thank you.
Thank you so much. I'll come back here so that I don't look like I'm biased. Can we move to the last row? We have Peter, we have Tana River, right?
Yeah. Thank you. My name is Peter from USAID. I wanted to comment on specialists sharing and training. This issue came up yesterday and was raised today again by Kata when she was speaking. USAID supported a very robust analysis led by the late Dr. Mwanzia James on specialist training and also sharing, and came up with a report that, among other proposed collegiate system of training, where the specialists are trained at the county level and only the lecturers or supervisors go in and supervise them. That way then counties don't lose on this very highly specialized workforce, still having to pay. And also the other way around were proposals also as another option of how to have the national government pick up their salaries in the event they really have to go. I'm humbly requesting that some of these reports and two others that had been done before that one on training of specialists be relooked at so that we don't reinvent the wheel, because solutions are already there and they're on the table. This is as late as 2020, 2021, and so it will be a good starting point for that approach. Thank you so much.
Thank you, Peter. Tana River.
Thank you very much. Listening to particularly the presentation by Daktari here, my neighbor, Kangu, on intergovernmental relations, we seem to be having lots and lots of structures, well defined. But every day we seem to be having issues between the two levels of governments. So my question is, where is the problem? Where is the problem and what is it that can be done? Because it does not seem to be getting easier. And maybe to crown it all, where does the buck stop? We are listening, in fact, I was listening to, I think His Excellency the chairperson of the Council of the Governors. There are even issues of going to court because of these kind of relations. And every day, the more I ask myself that question, the more I don't seem to have an answer on it.
Thank you so much. Very well put. I will still come back, but I would want us to quickly respond to some of these asks. Most of them were clear comments, and PS, sorry to put you on the spot. I would really like to hear your thoughts around the question on the policy on research and also on the Public Health Institute. If you have any rejoinder, if not, we can ask the presenters to respond.
Thank you so much. I think some things like NPHI, the syndemic, we cannot discuss. I know they're in court. We leave it to them, they'll give us feedback. The other one on issues of policy, I think now it is bringing us together. I think any policy we'll do, we are not the implementers. But I think this is a high time we start now incorporating the counties and make sure we are doing a policy which is well informed. I always tell people, do not make policies which might turn against you tomorrow. And maybe that's why we are in court now, because maybe we didn't do due diligence when we were doing that. If you look at NPHI and syndemic, maybe there's somebody who wanted to drive. And as we come in, you can find out the ministry is full of sagas. As health people, are we sure what we are doing? That's the only question I can ask, as I'm new. Because we find we have this saga, tomorrow we have this saga, Thursday we have this saga. And we are appointing people in boardrooms. Are we interested to be promoted to boardrooms or appointed, or are we going to change the healthcare service delivery to our citizen? I think now it calls for humanity and reasoning. What do we want as Kenyans to give our people so that we can change or a paradigm shift of service delivery to give quality service, and especially the public facilities? I think that's a thought, but the rest we cannot discuss. The issue of research I was discussing with her, because we have some bodies identified as ethical clearance for any research. We have KEMRI, we have KNH and University of Nairobi. I think we have MTRH and Acoustic. What do we want as Council of Governors? What is your recommendation that if County A wants to carry out an operation research, because you're involving patient, where do we get our ethical clearance? I think that one the Council of Governors should come out and outline that if maybe the counties have to do issues of ethical clearance, we need to have one. I think we need guidance from them, because it now beats as an individual, I'll go where it's easier for me. As a scholar, I usually used KNH University of Nairobi throughout my life up to PhD level. So as Council of Governors, for a well-coordinated body, so that we can have even a checklist and monitoring which are the research done, which do we need to do. I think they need to come out and clearly identify which are the bodies going to do our ethical reviews and ethical clearance. That's my take.
Thank you so much, PS. Very well put. I think there were comments on population statistics, which needs to be noted by our rapporteur. Comment on the report on specialists and in terms of training and sharing, and then the comment on the level 4, the PCNs. But I would wish Dr. Wamalwa and Dr. Mutaha Kangu to actually give a rejoinder on the discussion around community health assistance, and then also on the unbundling on functions and the tensions issue that are still prevailing between the two levels of government.
Yeah, thank you very much. I think really I don't think I need to give a rejoinder on the community health assistance. What Dr. Ganda is saying is basically that if you need to build in efficiencies, and that by digitizing you could save yourself some level of effort and have a better working community health system. So I'm 100% in agreement with the thoughts that he said in terms of digitizing community health and getting benefits around that. I think there was a direct question on the Kenya Public Health Institute to me, but I think that has been taken up very well with PS, and it's under ADR, so I don't want to comment too much on that, but just to say that probably conceptualization of joint bodies between county and national government could go a long way in solving some of the issues that we continue to see today. And the last comment I would like to make is just to add on, I think the PS said quite a bit around research, but there's just a bit I want to add in that there's quite some elaborate infrastructure at the national level. So if you see the national NACOSTI, the National Council for Science and Technology and Innovation, really gives all researchers a license, a permit, actually they call it a permit, to undertake. The NACOSTI also has pre-qualified a number of ethical committees which provide ethical approval for human-related research. So if you look through the NACOSTI website, I think actually now they've been expanded to, I think, even close to 20 different ones that can provide ethical approval. And I think that has been working well. But where the issue was coming in is right what Waziri asked in terms of at our level, at county level, when somebody walks in and wants to do research or wants to do an evaluation, what procedures do we have? What guidance do we have within the counties, and I'm not sure there's any policy guidance yet process that has been initiated, and I think that needs to be initiated to align that area so that we know that, well, we all know the role of NACOSTI, we all know the role of ERCs that are established. So when a researcher comes to the county level, what approval are they seeking? Are they seeking an ethical approval? Do you then take them through your own second level ethical approval? Is it administrative approval? And if it's administrative approval, then who needs to be involved in that? Is this, so I think those are the questions that we need to answer in policy so that the whole thing is well tied up. Somebody knows that I start with NACOSTI, I go to the ERC, and then I go to the county, and when I reach the county, this is what I expect. So I think that was the point that we were making around that. And if you look at that whole thing, normally policy and guidance comes to make things more efficient and effective as we move forward. So that's basically what I was pointing out. Thank you.
Thank you very much. Dr. Mutaha, I will request that we hold, I will still come back to all of you, but after Dr. Mutaha makes his responses, I will request that we move to Walter's presentation. Then I'll take all those questions.
Thank you, Regina. There was a question, where does the buck stop? Where did we go wrong? And I think the CEC from Nandi somehow has an inkling on where the problem is. How we managed transition from the centralized system to the devolved system. You know, we adopted devolution through a supreme constitution. And when you have a supreme constitution, you then say it is the highest law and all other things must be adjusted to be consistent with what the Constitution has established. So the Constitution established a devolved system of government and assigned functions, and then we gave responsibility to the transition authority to analyze those functions, to unbundle them, to identify the specific components of which functions belong to which government, and which of these are exclusive, which of these are concurrent, and then transfer them to the two levels of government. And you know, when we started, some process had started for that analysis. And then because of those tensions and conflicts I talked about, which are normally inherent in the system, the first governors said, transfer everything to us. And the president then said, take. And that was like, we ran away from responsibility to do things in an orderly way. And we are still resisting to go back and say, can we reflect and correct where we went wrong? And I will tell you, I have been going through Gazette supplement, Kenya Gazette supplement number 116 of 2013, which contains the legal notices that transferred all functions to the county governments. And you'll be surprised to find that in terms of health, those legal notices did very minimal analysis and unbundling of the various components of the health functions and transferred. And most important is that it only focused on what is being transferred to county governments, and those legal notices never analyzed and pointed out these are what remains to national government. And that's where the problems are. And I am happy that the president in his speech said, can we transfer the outstanding functions? And I'm saying we should not take the president's speech literally. We should take it as an opportunity. The president is telling us there is a problem we didn't sort out. Can we relook at this and sort it out? And we must not miss that opportunity. We must correct where we went wrong. And so when Ruth says another task force, what we should be saying is that, can we engage the Intergovernmental Relations Technical Committee, which now has that responsibility, and agree what process are we going to use to correct these mistakes? Are we all going to be involved there, the national government and county governments, and exactly what are we supposed to do?
Thank you so much.
Now, finally, there is, of course, the issue of intergovernmental relations. Where are we getting it wrong? And I said when I made a presentation that that is the one thing we have failed to seek to understand. And you know, we all must accept that when we adopted the Constitution, we all go out and celebrate that devolution is the biggest thing that our new Constitution introduced. But devolution is also the most complex thing in our Constitution, but we have refused to say, can we learn it? Can we seek to understand it? When you look at the Constitution and it says, national government has capacity building function, people take a narrow view that then it is the counties that need capacity. But the truth is that at the national government level, there is a lot of learning that needs to be done to understand the new system to be able to work with the county governments. So we need to go back to that, and that's why I said when Professor Mwanzi mentioned to the PS that we need induction for the national government officials, it is urgent. We have ministers in office new, we have PSS in office new, they have not seriously engaged with the devolution, they make fundamental decisions that affect devolution, and nobody is organizing an induction for them. So many of them will go to the Kenya School of Government to be taught about government management, government accounting, but not devolution.
Thank you.
And we will run into problems. The last thing.
No, Prof.
Just the last one on joint authorities.
I'll have to hold you. You will come back later because we will come
Thank
back
you.
again. We are really pressed on time. I want Walter to come on board and make the presentation on Maarifa. There are still people who had their hands up, so after your presentation, we'll go back to that discussion.
Good morning, everyone. Good morning once again. So I know I have 10 minutes, but I want to say a lot. So I'll try and squeeze whatever information I have within the next 10 minutes. So my session is on the Maarifa Center. I don't know, for those who are here, how many have heard of the Maarifa Center at the Council of Governors, or how many have accessed it? I'm asking the new ministers, forget about the development partners, because I know we work closely with you. So for the new CCs, the new Waziris, how many have heard of the Maarifa Center? How many? I know, Dr. Aden, you know about the Maarifa Center. So let us go through this and just learn what the Maarifa Center is and what it offers to devolution. And as you can see, the Maarifa Center shares Kenya's devolution solutions. And when you talk about solutions, what do we mean? We say this is a platform that hosts knowledge, and this knowledge is packaged in different ways. And this knowledge is on solutions that have worked in the devolved sector. So the Maarifa Center is hosted at the council. I think I'll talk briefly about this logo. And for those who have done communication, or the communication experts in the room, there's always something called an anatomy of the logo. So if you look at that logo, what is the quick thing that you can pick from it? If you look at it, we have two people talking to each other. One is giving light to the other, and that information is moving in a cyclic manner. So we are sharing information to all the 47 county governments in all sectors on things that are working. But the question is, do we share stories on things that do not work? Again, that's a discussion for another day, because in as much as we operate in a professional environment, we also have to look at the political side sometimes. So the Maarifa Center was established as a knowledge hub with support from the World Bank. And since 2017, we have been sharing knowledge products with all the relevant players in the sector, especially on things around success stories, sector-specific reports. We have our annual statutory reports and significant reports within the sectors, our state of devolution addresses, the newsletters, the press release. Anytime you hear press release, it's always uploaded, and many other devolution-related knowledge assets. And these are assets produced by our development partners and also other sector players. So, and we draw this from our mandate in Section 20 of the Intergovernmental Relations Act, which gives the Council of Governors the power to share information on the performance of the counties. And it's very critical, as I'll highlight in the next few slides, how we can use the Maarifa Center to solve development challenges. And that is very, very critical, because the purpose of sharing information on the performance is basically to help solve development challenges. And the center actualizes this through identification, documentation. So we identify, we document, and we disseminate. So it's a platform for dissemination. We share information, we do capacity buildings, and then we do partnership building. And then how do we collect and publish these stories? I think this is what is very critical for the new Waziris. One, we did a letter to counties to nominate knowledge management champions. So you are supposed to have a knowledge management champions, because again, if we say we are going to recruit knowledge management officers, it becomes a tall order, because we're also looking at the wage bill issues. So why can't we then have the internal capacity and just nominate somebody to be your knowledge management champion? And this one, we normally recommend that you have either your M&D officer or the communications person as your knowledge management champion. And then these champions, they provide information on success stories within the county. What is the good practice that you have borrowed from somewhere that you have scaled up and it's working well? Or what is the best practice that you have adopted from somewhere else that is working? So this is something that we do. And then we also get stories from the newspapers, from the websites, from fieldwork, especially when we go for a mission to a county, and you hear a good practice story that is something that we say is impactful to the community, and it is something that we have not witnessed in any other county. So we pick that story, we package it, and then once we package it, it's verified at the county level, it's approved, and then it's uploaded. So the approval must always come from the county. The reason why, because we can't upload a story on the Maarifa platform if you have not approved at the CEC's level. Because you can easily disown that information and say, this is not the true picture in our county, especially if somebody raises a query about that. So you have to approve the stories yourself. So once you approve, that is when we can upload it into the Maarifa platform. So please take note of that, because your knowledge management champion, from time to time, will be sharing stories with you. And I know the health sector is the one that has the most stories in the Maarifa platform. And one of the things that we do a lot is peer-to-peer learning. And I think I've seen it going on even in this room. It can be informally, it can be formally. I think I saw Dr. Aden with a group of CECs just learning on how you managed to achieve what you did in Mandera, which is very exemplary. So that is a form of peer-to-peer learning, because we are sharing knowledge between and among ourselves. So the platform is also a peer learning platform, because when you see a story about what is happening, maybe in Samburu, where we had these manyatas constructed as maternity wings, then you can pick that story if the context is the same and try to also replicate the same. In terms of the health sector, I think I want to highlight some of the things that have been happening in terms of peer-to-peer learning. There was one on FIF and CHS that brought together 15 counties. And the aim was just to provide a platform to share and learn from each other on the FIF. And I think it's been going on for quite some time. And we now have a model FIF law that will be shared with the counties. And also understand the role of CHS digitization. And I wanted to highlight this because when I say that we use peer-to-peer learning to solve a development challenge, the issue that Dr. Ganda from Kisumu mentioned about digitization of the community health system. Now we are talking about a deficit in the number of community health assistants. But now they are going to bridge that deficit because they are using technology. And where did they learn about this technology? Is from Isiolo County. So you can see how learning from each other can help us solve development challenges. And that is something that has been proven. And that is why we encourage a lot of peer-to-peer learning. We are at a stage where right now we can't go outside the country to learn about community health systems. We can't go outside the country to learn about FIF because it's something that is working. There are counties that are doing it well and it's working. Can we learn from them? And that knowledge is free. There's no county that will charge you for sharing knowledge. So I think that is something that is going on. Also, we have our, can you go a slide back? Yes, that is what I mentioned about Kisumu learning from Isiolo County. And there are also other counties that have done well in terms of community health system. I don't know whether Kitui is in the room. I used to be stationed in Kitui South where we helped establish the community health system, and it was working very well, so you can also learn from them. And then all these stories, sometimes we package them in a book we call the Compendium of County Innovations. So right now we are in our 3rd edition. I think in your handbags you got the copies of the compendiums. Please take time and go through them. You will learn a lot on what has happened in the health sector. And these are just the highlights of what you'll get in some of these compendium. And these are things that the county, the innovations that the county tried during COVID. Like we saw Machakos converting their stadium into a COVID response center. It's a makeshift hospital. But we never saw any other county replicating that, though we were struggling with the 300-bed capacity. And then Kericho County, for instance, used mitigates the inadequacy of reagents by using radiology to test COVID. I think this was also tried and it worked. Also on the issue of providing the dedicated medical care for its health workers and their families during COVID. I think these are some of the things that we documented under the health sector in the first compendium. This one is in the 2nd edition of the compendium, which you have. I think the last one on HPTs, because I see HPTs is also something that's is being now institutionalized as well in the county, so maybe you can learn from Vihiga how they have actualized it. And then if you go to the Maarifa Center, you will find some of the stories under each sector. So let me go to where you can access. Now this is how you can access the Maarifa Center. This is the URL, maarifa.go.ke, sharing Kenya's devolution solutions. So if you look at the tabs, you have the home, about, success stories. That is the tab where you will find success stories. And if you go to a specific county and click on the county, you will see some of the success stories that you have managed to share with us. 10 years or 9 years down the line, there are counties which have never shared even a single success story. So we will be reaching out to you so that we get those stories. I know they are there. It's only that you haven't shared. And then we have the resource library where you will get all the resources you need. If it's the CIDP, the annual statutory reports, the sector reports, the devolution conference reports. You will get them there. And of course, we normally share events within the platform. So please take time, go through the platform, especially for our newer series. Just learn what is going on there. Look at the stories that are shared. So ensure that your county is represented. And then this is our Twitter. We are also on Twitter so that you can follow us if you are on Twitter. And at Maarifa_Center. Because we normally, all the stories that we publish, we have to share them through our social media platform for visibility, not only for the council, but also for the counties, so that even people outside the devolution space can know what is happening. Thank you. That was my last slide. I hope I've taken 10 minutes.
Thank you very much, Walter. Can we appreciate Walter in a very special way? He's done us a good job. But I saw one student who was looking at his phone when the class was going on. So, Yumbia, I have a question for you based on the presentation that has just been done. If you want to send a tweet to the COG Secretariat, what is the COG Secretariat's Twitter handle? Can we give Yumbia the microphone? Microphone to Yumbia. Yumbia is on the other side. These are the people who are busy looking at their phones when the presentation was going on. We want you to share some of the good experiences. What is COG's Twitter handle? Okay, your voice is loud enough.
I think the website I've got is https://maarifa.cog.go.ke. That is what I have. And for me, I've worked with COG for a long time. And the experience I have with them is that Katra, you gave me a microphone. Katra is hands-on. And whenever there are challenges, I just call and consult. I think for me and her, we've got a working relationship that I may not even go to the tweets. What I got this morning is a photo where we are seated in the PS. It just come from Machakos, and they are sending me the photo. And I'm trying to look at COG, there's nothing. I'm trying to look at the PSCs, there's nothing. I don't know where the photo came from. And yesterday's photos are missing.
Okay, Yumbia.
The photo I have is when I'm listening. But when I'm talking, no photo. So for me, I like action photos. I've been unable to send to my people the photos because I'm just a passive participant. Thank you.
Thank you, Yumbia. First things first. It looks like that information was given to you by your next door neighbor, so you had Mwakenya.
Madam, usiniharibie. I think on my feet.
You already have a supplementary, because even the way you answered the question was wrong.
Go ahead.
Please be seated. Ladies and gentlemen, please welcome Dr. Benedict Osoro to give us his presentation. And you better be attentive in this class, because this prefect is no joke.
Yes, thank you, Chair, for the session, Regina. I like that people have to be attentive, so that you can walk out with something. Really, I think mine is to come and share with you just a few thoughts here and there, coming from the ground. And I'm told I've only 30 minutes. So Dr. Wamalwa, Mutaha Kangu, Professor, did quite a bit of issues to deal with the governance and management. So I'll just walk you through in a few areas and just show lessons learned. What are we doing on the ground? I formerly worked in Nakuru as the director, but previous also at the province. So I've seen devolution. So for us, devolution has worked. We can only make it work better. And it's looking at what is there. And so the outline of my presentation is just to giving guiding standards, look at the key considerations, lessons learned, structures for consideration in terms of like we're looking at organogram. Do we have a uniform organogram which is functional, related, or sometimes we'll give it in terms of cadre? Seeing my former CEC Nakuru, but then who is now in Nyandarua, and remember when we were developing one for Nakuru, he was so particular that we move away from where cadre, so people are looking at positions and inter-cadre conflict, but we look at in terms of functionality of the health sector, so that really it reflects the functions. And even when you're going to plan, you can allocate resources properly. Then eventually probably we might have one or two questions. Next slide. So what are our objectives? To appreciate the guiding standards and organization in the county health departments in terms of delivering the health function as per the Devolution Act. And then eventually share experiences. What has worked? I know quite a number of you were in the previous dispensation, but I know after elections, many county governments changed. And I think with that, a lot of change in leadership. And I think that's what has necessitated this particular induction, so that really when you're having a big number coming in, it will be good to start on the right track so that you're able to move on. So I think the various legal documents mentioned there, I think were done by Professor Mkata Kangu, so I'll not really go back on them. But there's the issue about recommendations on various rationalization programs, like the capacity assessment and rationalization for public service. Really, what necessitated this? We realized that as we got evolved, we have 48 county governments. So there are those who remained at the national level and those who came at the county level. And I think it was very important that we were able to come and assess, do we really have the numbers and the cadre mix that we require at both levels? And then occasionally, we might need to have transfer between the two areas and even sharing of some of those services. So I think that has been very critical. It's a document it will be good to look at and see what it said and its recommendation. So CAPS, it's good for you as CEC to look at it. It has quite a lot in terms of the human resource component and even the other cadres that probably we've neglected. Because I remember like in Nakuru, when we were operationalizing the oncology center, we realized that really some of those specialists were not captured in IPPD. And so we had to link up with the national level so that we are able to, as we are doing recruitment, so that they are fit into the system. And I think it's very important in terms of that. And it can also help in terms of redistribution of staff within the county, because we are looking at devolution and decentralization. So we are looking at the issue of equity and representation. So I think it's very critical anytime you're doing that. And it can also be a justification if you're trying to mobilize resources, that such a report would help you in doing that. So there are policies and strategies which have been laid down, and I think Dr. Wamalwa took us through those. So all of you have seen them. There's something about collective bargaining agreement. I think when he was talking, I think he looked at the various stakeholders in health. But I want to tell you, CECs, there are people we call unions. I think sometimes can really drag you back, and whatever your gains that you've made can really be taken lower down. We need to engage them well. We need to follow the legal structure that is there so that you can have meaningful engagement. I'll give you an example. The unions will come and they're not conversant in terms of your resources, in terms of your planning cycle, when your budget comes, whether you have that item in the budget, but they're pushing, they're saying, we are downing tools, we want this. No, you're not going to lie to them when you don't have the resources. But if you engage them, you sit with them, they actually come to learn, and you do also a bit of capacity building for them. They realize this is how the county government acts. This is what is in budget, and this is what you can appropriate, and this is the process of how funds are disbursed in the county. And this is what you have in a strategic plan or annual work plan. Then they'll appreciate it better and probably will engage in a better way, as much as they are representing the workers. But they also need to know that how the system works, that there are some things which you might not be able. And many a times, you need to work with other key people in the county. For instance, if you're meeting the union under the CBA, and you find you've left your counterpart, for instance, the chief officer might be the one representing there, he has left out the finance guy, the planning and budget team is not there, the county public service board are not on board, then probably you're looking at recruitment. And it's a process, and they're telling you, we want this number of health workers in 2 weeks' time. Yet you know the recruitment process might take you 3 months. So those are some of the things that collaboration will go a long way in terms of helping. So the health functions, I think these were well covered. I think let's move to the next slide. So I think let's move on. About the linkages, I think this was already done. Now, I think when we are coming, just go back a bit. In terms of the various groups, in terms of the TWGs and all that, I realize that it's always good to have this in place. But you find sometimes when you're working with partners and in terms of coordination, everybody has their own interest. And sometimes it's good to have a uniform way of handling so that if you're going to have the various groups like the TWGs and the rest, there should be also things that can work within the county. Because many a times I think what has happened at the national level, you envision whereby you would want something. Like I'll give you an example, the time we were trying to reorganize in terms of blood transfusion services. So I think as counties we were told, can you get us a focal person for blood transfusion services? Then you come down and you look, you have a lab coordinator who actually looks at all the lab issues. So really you find that the CHMT, you cannot really accommodate so many people. So many a times you find that sometimes, and the national level is coming with this, it will be good, it comes from the forum of the CECs, who can actually own and see so that it really comes and fits into the structure, so that through the various forums, the chief officers, the directors, so that by the time you're coming on the ground, then really it works. Because we'll have an over-established CHMT, yet for us, service delivery is so key. You'll find you're told there are too many people at the CHMT and the sub-county team, yet services are not being offered down there. So you find that some of the roles can be handled probably by the same person and he can connect more functions so that we really reduce that having a bloated management vis-a-vis yet service delivery is very key in terms of delivering the services. I think on this slide probably let's just move on. Yeah, some of the lessons learned. Please, you're a bit too fast. So we need to improve, just go to the next. We need to improve coordination and collaboration at interventional level. How do we do this? And I think it has come out from this forum that having the various caucuses for the CECs, the chief officers and directors, it will really help in terms of coordination. So that when we speak from here, we speak with one voice and we share information down the line. As somebody had said that there are times people don't share information down or they are so busy. You hardly interact at the lower level and sometimes information does not trickle down. So I think this really will go a long way to help that so that we share information. Then effective implementation of county programs using program-based budgeting. You know, as counties, we expected to budget. Normally, we are guided from the Department of Finance and Planning. And as we develop our annual work plan, we always have to go back and look at our strategic plan. We look at the national level documents and even the regional and international documents. What do they portray? More importantly, also, as usual, you look at the manifesto of the governor. You want to make sure it's incorporated in what you're planning so that they are captured, those activities, so that you'll be able to implement and so that you'll be able to appropriate the necessary funds. The planning tools are actually very elaborate and very clear. I really want to thank the national level, having developed most of the key documents, so that as counties, we need to make sure that the process starts from the bottom up, whereby you're starting at the community level. And I want to thank Dr. Wamalo bringing that aspect of self-care. It's somewhere which is a very important service we've always neglected, but also let's look at the household level. What is it that people are able to do at that level? As we come to level 1, then as usual, we make sure we use the same uniform planning tools to level 2, 3, and up to the CHMT, sub-county level, and then the CHMT level, so that eventually you're able to consolidate that document and come up with a plan. But bearing in mind that you have to go according to the planning cycle, and so that you use the right template and make sure you are people-oriented, so that actually you come up with a document. The challenge is many times we come up with a plan. Then some of the workers, I think traditionally have believed services will come whether you have a plan or not. So they'll go back to the traditional way. What we are really emphasizing is that can that annual work plan have a quarterly implementation plan? And that should also be tied to the resources so that if people are coming for an AIE,
you look at their AA, is it in keeping with their annual work plan and the quarterly implementation plan, so that you are really delivering on the key areas? Because if you look at program-based budgeting, it looks at the various key service delivery points. You are looking at the outputs and how are you going to deliver and with the targets that you've set. So I think it's very critical when this is happening at the level of the county. So looking at some of the structures we need to support is in terms of improving of equity and quality of care. So what has happened on the ground? I'll give you an example, like in Nakuru, when during the first devolution, the first government in 2013, 2018, I think when we came on the ground, it's like through the World Fund, we decided we are going to put up quite a number of level 2, level 3, which we did very effectively. Then after that, the next dispensation looked at, now how do you link the referrals? So level 4 were probably critical this time round. They moved to that. But you find that when we are doing this, sometimes we look at the issue of equity, because you look at the county in terms of the county, the sub-counties, and the wards in terms of representation. Then if you look at some of the WHO guidelines in terms of the radius, in terms of the physical, but also in terms of the population, sometimes those might not be followed up. And so that you might be able to operationalize looking at equity, but it's not translating into better service delivery. And sometimes there's usually a lot of political pressure, and it can be very tricky. But all said and done, sometimes also you find that we'll be able to do the structures, but the structures, as you see, the building blocks in terms of WHO are very clear. We might not have budgeted for the human resource, the equipment, the commodities. And so what happens when the project is over? It remains a stalled project, because you have not operationalized. And people are going probably for elections in Nakuru and Nakuru muhimu sana. So we always need to make sure that in our budget subsequently, that is also reflected. But the challenge when you're working within the World Fund vis-a-vis what you get at the county level, but that collaboration will be very important, so that as you engage the members of county assembly at that level, then you sit with them so that at least you appropriate resources so that this is actually implemented and services are delivered to an NGO on the ground. Then, to reduce duplication of health services. I know this can be both at the national and county level. I think they have discussed about that. But we have agreed, we've seen what our roles and functions are. But progressively, as we work through collaboration, that should not really become an issue. But I think in counties, look at health in totality. Look at everybody who is providing health services. How can you work with them? How can they share the data with you? Especially when it comes to times of pandemic, or we are giving the health promotive aspects in terms of vaccination. If you don't capture the private sector, many a times there's quite a lot of data that is there, a lot of services that are going there, and probably some of them will be very good quality, some might not be of good quality, and it might affect overall service delivery. You might find that your reporting rate is low, yet if you just engage the private sector, when they share their reports, then your reporting level just out of the blue improves. I'll give you the example. I was telling my CEC there to have stood. You remember during COVID, when in Nakuru, we sat down and said we wanted to involve all stakeholders. We brought them on board. We started with the press so that they're able to report properly, and when they are going out there, they know what is happening. We looked at all the other key stakeholders when we were doing to plan, when we were rolling out, we were doing trainings, sharing resources. And even when it came to beds, we were not strained because we were able to capture what was available, and we were able to reach. And many a times Waziri would not have a lot of phone calls, because when somebody went to a public health facility and it's over, already has enough, the beds are at 100%, we would actually be able to refer them to the private sector, and they still got services. So that collaboration and working with the others, I think, is very important in terms of making sure services are improved. So we can move to the next slide. So, about health, disaster, and emergency and disaster responses. Yes, if you look at the County Government Act, it's very clear in terms of the emergency fund, you should allocate about 1% to that. But really, what happens when an emergency, an outbreak occurs? Like our friend in Tana River, once it occurs, to be able to get to the CEC Finance, the chief officer, then you sit as a group, then you'll be able to access that. It takes a bit of time. So what do you do under emergency conditions? You find that many times there's a lot of expectation from the department. And the public emergency operation centers, which we are able to operationalize in the counties, have really come in handy to help us do that. So that through disease surveillance, the moment we get suspicion, then we kickstart. So like for us, we made sure that the CHMT, we have the primary health care committee that really looks at that. So the moment you look at from your weekly reporting in terms of event-based surveillance, then you become proactive so that by any time you suspect, then go and investigate and also share with the national level. And then from there, many times if you're overwhelmed, they'll come and support you and you'll be able to, and then also sharing with your neighboring county because these diseases don't obey boundaries. And you'll find if there's an outbreak, I'll give you an example. Whenever there's an outbreak of cholera in Nairobi, be sure Nakuru will be next. If it's in Kisumu, you know Kericho, you know along that transition, we're on the northern corridor. So always as Nakuru, we're always proactive. The moment we hear it's in Nairobi, we prepare ourselves. So we make sure that our teams are on surveillance and they look out for it. So don't wait until it's too late. So it's always important to do that. Then in terms of planning, monitoring, and regulation, yes, I think all of us need to have strategic plans as counties. We need to have annual work plans, which we shall be implementing on a quarterly basis. As we move in this dispensation, this is the time to be able to do that. And with guidance and support from TF from the national level, for those who have not gone through this process, it will be good so that it helps you to plan, you're able to cost those services, and you're able to use that to get more resources. In terms of curative services, I know we've done well. That's our core business. But curative services, we know, are so demanding. So probably we will need to have a paradigm shift. As much as the non-communicable diseases are becoming a big issue in the counties, when you're looking at the cancers, diabetes, hypertension, and upper respiratory tract infections, we need to look at the preventive aspect. How do we prevent hypertension? We should not wait at the tail end, whereby we are putting resources, waiting for people to come with end-stage kidney disease, people coming with the advanced cancer. My brother from Kisumu, Uganda, is doing a lot of work in terms of prevention. You know, he's an expert in oncology in Kisumu. So that they're screening. Are we screening our women down there so that we can prevent cancers? Are we checking everybody's blood pressure and in the community in terms of diet and lifestyles so that we can prevent some of those things? So that we can actually invest more towards primary health care and eventually reduce the curative aspect and eventually probably mobilize those resources in that direction. So primary health care actually should have, even in that order there, should be up there so that it's really showing where we are. We have talked about UHC. We have the policy documents, very clear our roles at the county level. For those of us who have not probably disseminated and rolled out, it will be key to be able to do that at all levels, including the county assembly, so they should know, so that if you're seeking resources for some of those areas, the health committee should be there so that they support your budget and so that you can mobilize resources. Like, I'll give you an example for a county. At one time, we shared with them in terms of the stipend for the CHVs. The county assembly moved very fast. They even offered it above the national level. When we captured in the budget, it was in a lump sum somewhere. So they went and said, Toai. But when we went back and had a session with them, tell them before the supplementary budget, I told them this is what is going to help in terms of the community health volunteers. They quickly actually realized and said, we should actually even give you additional. We gave you actually lower, we underestimated your costs, and so they'll be able to really address it. So it's always good to look at it. Nursing services is also very critical. Nurses work at all levels. They form actually the bulk of the health workers in the department. And so you find when you're recruiting, they'll be the bulk of the people that you have. How are they represented? So probably it will come, I'll show you in the organogram. I think some of the counties, we've never looked at them, so they always feel they're underrepresented. Find the nurse at the dispensary, the nurse at the health center really does most of the other work that all other cadres which are not represented down there should do. How do we make sure that we support them so that they also, we do capacity building in terms of the various other roles they represent the other cadres so that actually they share the right information upwards and so that we are able to capture that. Health promotion, I think, is very clear. You looked at the ministry in terms of the policy paper. We are looking at health promotion as very critical, especially at the household level, at self level. So we really need to invest in that area. we need to support our health promotion officers in the county and be able to have that structure going even up to the sub-county level so that those activities actually go on. Program coordination, I think, is very critical. And as a county government and as CECs, make sure that that is happening. Like in Nakuru, because of that partners, the various partners we have, it was prudent the CEC at that time appointed at least a director who actually deals with partner liaison. And we've been shown the guidelines from the national level. We need to domesticate them at the county level so that eventually actually we have proper partner coordination. Because sometimes you have too many partners on the ground, yet they're actually doing more or less the same thing and duplicating and reporting on the same issues, yet really not even changing in terms of service deliveries. So partner matrix to see their roles and responsibility, what do they do, and how to make sure that they are not concentrated just probably to 2 of your sub-counties which they think are near where they can work, but you make sure that there's also equity along the way. Training is a national function. It was mentioned here. Probably I'll not go back, but I think it's important as county governments to make sure that we do capacity building. The health sector is very dynamic. It's changing. We need to make sure our people go to school. But we have to balance that with service delivery. Do we have training committees? Do we know in terms of how many people have been trained through IRIS? Are we training the same people over and over? Let others are not. Then can you do equity per sub-county and see, are people trained in the, like if you're looking at reproductive health, you are looking at malaria, TB, is there equity in terms of that? Then there's a lot of attrition and people leaving the service. Some of the highly trained people are leaving. So who do you have back there? Like in our county at one time, we realized that, I think one time JICA wanted us to have biomedical engineers go for training, and they had put over a cut-off age. Among the ones we had in the county, none could meet the criteria. So we had to get the one who was on contract to be able to go for that training. And the same is emerging with the other cadres, that those are the people we need to do capacity building. So if they are with us, probably from being on temporal basis, they should actually move to P&P so that eventually they should not have a challenge in terms of going for training. Then when they're going to training, are you bonding them? What is happening? Are they going to come back to deliver services? Can we use different regional training approach where the students are actually learning within their region so that they can also be offering services within the counties? So decentralized training like COSEXA and others should actually be the way to go for us so that we don't lose on some of those human resources. Good. Health supplies and logistics, I think it's very critical. I'm seeing she's just next on me. Let's move on. Probably, let's go next. Let's go. I just want to look at the organogram. These other things are, yes, structures to consider in terms of the structure there. Look at this, the up there, then the departments, the sagas on that side. If we are going to have them at that level, probably we'll have a different name. We look at the various directorates, divisions, sections, and units. Then in between there, the administration in terms of the sub-county administration, ward administration, and village administration. Then as usual, we have the urban areas, which are also within there, because when they plan, there are health issues within there. How do we coordinate with them and collaborate? Then the next structure, which probably all of us will go and compare with what we have, so that if you're going to revise or review, then probably this could also be part of the guidance in terms of what you're going to do. So we look at the stakeholders on the other side, the county health management team, the sub-county team, health management teams, the health center dispensary management teams, and the hostel teams, then the community health level, so that all the levels are well represented in that, and that flows, so that it really helps in terms of being devolved and being decentralized. So this is just a structure we wanted to share here. Just you can look at it, and when you can also give guidance. And as a county, because you might be unique in a way you would want to offer your services, you can make a bit of modification and so that you have better service delivery on the ground. Next. So this other one is really representing probably what organogram some of the counties have. And you're looking at this. As usual, the CEC has never been an issue. It's always one person. When it comes to chief officers, most of us counties, we have two. Most of us have two in terms of chief officers. Because we usually have medical services and public health or primary health care and sanitation. When it comes to directorates, I know at one time Kakamega had 3 chief officers. Yes, then county director. Do we need to have, like, looking at this structure, do we need to have one county director? Then below him, we have the 4 directorates that have been put in this organogram. I don't know how well it will fit so that the other cadres also feel represented, or the services, so that there's a bit of better, so that the county director is not overwhelmed, so that he has these other 4 officers answering to him, and probably for better and smooth service delivery. I know the issue of HPTUs in terms of commodities has not been captured here. Whether there's need of a 5th directorate is probably something to think about. And then as it breaks down in the other areas, I think it's very clear. So next, whatever structures we adopt, ensure that all key posts have comprehensive job description, JDs, we make sure we develop that so that people also feel motivated. I'm given a position, but it does not come with something to take home. We need to motivate our staff, set out clear lines of accountability, and in terms of hierarchy, somebody should not say director of medical services. So the guy in administration, when he's giving instructions, you don't want to take, you want it to come from your knee. It should not, because these things are interrelated. Ensure that appropriate size and well-sufficient, not excessive control in terms of the numbers and of establishment. Enable the county executive and governor to regularly be informed on the progress of health services. How do we share information? At the CHMT level, to the director, who should also share with the national level, to the Director General at the national level, and to the county assembly. How do we share information? I think we should have very clear lines of sharing. But before this information is shared, it should really come through your office for concurrence and, yes. Then orientate health boards. Yes, you looked at the health management structure there in terms of the governance. We have the various boards at the hospital level, at the health center level. So we need, whenever they have been appointed to their positions, we need to orientate them on their roles and responsibilities. We need to make sure they are gazetted, and so that they can support and the community ownership comes in terms of the services. We need to work with the community. So it's a key aspect, and we should make sure that that is working. One of the things we did in Nakuru County, apart from having that at the sub-county level, even the CHFT members became members of the sub-counties, so that they're able to support them on a regular basis on some of those technical issues, so that things are not left just like that hanging. Great, I think I'll stop there. I'm seeing the chair of the session is just on me. Good. Is there another slide? I think that's the end. Yeah, I think that was the end of it. Thank you.
I wish to correct that I was not on his case. I was just giving him protection. Ladies and gentlemen, let us give Dr. Osore another round of applause. He had actually indicated and given us some of the lessons, having been there, seen that, done that. And so it is a good way of actually understanding what happens at county level. At this juncture, I want us to go straight into the panel discussion session that will be discussing the role of development partners and private sector in advancing county health agenda. Please note that there are some of us who had actually requested to comment after the first presentations. Please note I have not forgotten you, so just put your notes together. Once we finish this session, you'll be the first people to do your rejoinders or comments. In this session, we will have Mr. Joash Dache, who is the CEO of the Kenya Law Reform Commission. Mr. Dache, wherever you are, please make your way to the podium. A round of applause for Mr. Dache. We also have in this panel Honorable Lady Justice Jacqueline Mogeni. Lady Justice, I don't know if it is at this point that I bow as you come. That was with a light touch. Please welcome to the board. A round of applause for Lady Justice Jacqueline Mogeni. In this panel, we also have Professor Richard Muga, a professor at Uzima College. I don't want to use the word outgoing because once a CCM, always a CCM. A round of applause for Professor Muga. And finally, we have my sister, Wairimo Gakuo, who is a partnership team lead health at the USAID. Can we clap for Wairimo until she gets to the podium? So as the moderator, so that I don't look like a preacher, woman or man, I would request that this podium is moved. So I'll be the moderator for this session. I don't know why the mic is misbehaving, but I just want to start off the discussion by asking my panelists in a very quick way, and you'll allow me to use your first name so that I move away from the titles. Given where I come from, the S and H thing can be an issue. So Joash, to all my panelists, I first want to start by asking you, when you're talking about advancing county health agenda, Joash, what really rings in your mind?
Thank you, moderator. When we talk of advancing county health agenda, what comes to my mind as a lawyer is that 99% of health services are devolved. The national government has remained with very little. And therefore, the challenges that I was hearing during the presentation, particularly by Dr. Kangu, those challenges should not be arising, because in my mind, health services have been devolved. And county government opportunity, unique opportunity, but in terms of budgetary allocation, and therefore they need to run this.
Thank you, Josh. I think what Josh is bringing out, that the moment he hears advancing county health agenda, the first thing that takes in his mind is that health services have been devolved. Did you say 99%? 99%. Jackie, what hits you when you just hear the word advancing county health agenda?
Okay. On my part, when I hear the words advancing county health.
Can we hear Jackie, or do we need to give her 3 mics?
Okay. No, I'm okay. I'm actually very loud, I can speak without the mic. Yeah, so I actually think about the counties mobilizing resources to be able to provide top-notch health to all the citizens within the counties. And in terms of immediate response to what you see that is plaguing the counties in terms of health, but most importantly, ensuring that adequate resources are there in terms of the personnel, the personnel who are basically addressing the health challenges that are facing the citizens, but also any issues to do with resources, seeing how best you can be able to mop up what is there, and also ensuring that when we say we are advancing, we are basically saying we want a healthy population. So what does that therefore entail? So doing everything within your power to ensure that your population is healthy, environmentally, socially, politically, and health-wise, so that now we say that we are having a healthy population within county X, and we don't see the problems that we, as my brother said, the challenges that we've been speaking about from day one.
Thank you so much, Jackie. What Jackie brings out so clearly is that for her, it is having every Kenyan healthy. providing top-notch. I think if I got the words, top-notch. I hope you all got the words top-notch. We'll get to hear what top-notch really means as we get along. Prof, what makes your mind tick when you hear the word advancing county health agenda?
Thank you very much. When we hear the word advancing health, county health agenda, we think of the holistic definition of health. That's the first thing. That every person in the village can remain healthy and can access it without barrier under the leadership of the county government, because that is the reason it is devolved. And then working with the different partners to help you realize this. And then creating tools that you need to help you lead, to help you implement. What you don't have, you need to find a way where to get it. And that the poor man, like the picture we were shown this morning, the one on the wheelchair, he cannot access the health facility. The old man who is blind, he cannot go into the facility. And then a family with 10 children and they have no resources, they can also access it. So for me, that is what rings in my mind.
Thank you, Prof. What makes you tick when you hear advancing county health agenda?
What comes to my mind, and it's a theme that has been going on since yesterday, is change. That change is happening, and it may have started much earlier than we thought about, but devolution brought a lot of change, which means our relationships are changing, how we do business is changing, and who takes the lead is changing. We talked about devolution a lot this morning. Counties are the lead in offering services, but they don't do it alone. There's the relationship between national, county, and lower levels, and which means that the role for stewardship is key, but the role of implementation is shared between many actors, including development partners. We are in this space working with all levels, trying to get efficiencies with a reducing amount of money, but each of us has a role to play, and if we play it all well, we will get better health for the people of Kenya. Thank you.
Thank you very much. These mics are really doing us disservice, but we will try. Clearly, you can get from my panelists that they understand the context within which they were actually identified to be panelists. And so on that note, I just want to go back to you, Josh. Wairimo has talked about change. Where you work, it's about reviewing of laws, legislation. Now we are looking at the role of development partners and private sector. As you review those laws and regulations that relate to health, what do you really think is the biggest game changer in the context of devolution?
Thank you very much, Madam Moderator. In terms of the role of development partners and private sector, particularly in health, and vis-a-vis our role as Kenya Law Reform Commission in reviewing legislation, it is very important for county governments to take into account several things. I'll mention just a few. One is that development partners and the private sector are really key in the provision of health services. However, you must be able to target the vulnerable, the most vulnerable group within the county when you are selecting your partner, whether a developed partner or a private sector. Number two, you ought to be very careful, particularly with the private sector, so that they don't crowd out. The partner that you are bringing does not crowd out local providers of those services, which give our people jobs. You must be very careful that the partner that you are bringing does not crowd out those who employ our people. We also, as Kenya Law Reform Commission, when we are talking about development partners and private sector reviewing legislation, we take into account the issue of incentives. We must give these people, particularly the private sector, tax breaks, for example. You must give them incentives so that they are able to invest within the county. Thank you.
Thank you so much, Josh. I think there are there's one key pointer. Thank you, Josh. I think there's one key pointer that you've really brought out, the issue of crowding out. I think in some class that I went to once upon a time, it was called Watch Out for the Dutch Disease. So if you know what the Dutch disease does, you better watch out. But looking at that whole aspect of thinking about, not crowding out, Jackie, I want to come to you. Once upon a time, you were the conductor of an orchestra called COG Secretariat, and you worked with these folks. I just want you to tell us, what did you see? What worked? What did not work? What were the hits and the misses that made your orchestra just give some tunes that were not aligned to what we needed to get?
Okay, thank you very much. Thank you very much. You can hear me? As you said, we have the drama with the mics, but we'll try. Now, that's a very wide question, and so I'll try to be brief. When devolution happened, of course, at first I was at the Transition Authority, and then I was asked to come and support setting up of the Secretariat. To begin with, at first, the transition had not given certain counties health functions. Why? Because the assessment that was done, we realized that some counties that did not have capacity, so to speak. But when I went on to support the governors, we decided that let's apply, because in the law that changed said that you apply. If you have capacity, you apply and appeal. So I told the governors, please apply. So we applied, and it was kind of a conflict of interest because I was the chair of legal on that side, and then I'm helping on this side. So I write the letter, then I answer it myself. So then we applied, and I approved for all of them, for all the health to go to all counties, and of course we gazetted. The truth of the matter is there were a bit of challenges because we went a big bang, the style of everything goes. The first challenge was resources. The first presser that the governors did, I remember, was about resources. 190 billion is the one that had been given to them. And so the chair then, Governor Ruto, said, Mogeni, do a presser. We have to tell the national government this is not enough. So, of course, I quickly ran around and did a presser at the steps of City Hall Annex, and we said we need more money. Of course, none came, however. But the health function went, and then the first summit that we had, there was a negotiation, a mutual negotiation between ourselves and the county national government, and the county governments accepted to give away vaccination, the immunization. That is a county function, but they gave it away in quotes because there was no agreement signed. You know that for you to give away any function, you have to sign the Intergovernmental Relations Agreement, an agreement under the Intergovernmental Relations Act. And so that was the first miss, because you are in charge of a population that needs to be healthy, and then you've given away a function that ensures that children, when they are born, they are well immunized. So that was a mistake. But then we have lived with it. And one of the things that we negotiated was, yes, now we've allowed the national government to take immunization, but the structures that will be used should be the county structures, so that we are not having a situation where people are immunizing and you have no clue that that's happening in your county. And so as we went on, we realized that there was always acrimony between the county government and national government when we are doing immunization, polio, measles and all that, because development partners would come in and support directly their partners on the ground and and counties would just be hearing, there's a polio vaccine going on, and nobody knows when it started and when it was announced. So that was another miss. And then the other miss was the issue of equipment. By the time we were doing the MESS equipment, which we are all familiar with, counties had already equipped themselves. I remember the governor for Meru saying, I already bought this equipment from Germany. I already had them. And the miss here was because of communication. The governors, I remember the first meeting we had, we had a meeting in Naivasha, and the governor for Siaya put up his hand and said, when the national government was convincing the counties to accept that we could buy equipment, and they said, we want the equipment, however, assure us that this equipment, we will choose what we need as counties, and this equipment is not going to come from China. I don't know why he had anything against China. We want equipment from Germany. I don't know why he preferred Germany. And the counties were assured that indeed the equipment they will choose, it will depend on their gaps, and it will indeed come from whichever country they want. This never happened. We all know the story that has been going on. And why did this happen? Because the CECs were carried in Prados, and they went to the university, that's university on Ngatarongai, what is it called? Multimedia. And they signed the agreement, which to date, every county has never seen. So that was another miss. It's because of miscommunication. And then the last miss was the issue of KEMSA. I'm just picking a few, the milestones, where through a miscellaneous amendment, through our brother here, they quickly made a change and said that only KEMSA will be able to supply medicine to the county, and you can only buy from KEMSA. It was never there. Actually, it was an amendment that was done 2 years before I left the council. And the disadvantage of it was that whenever there's no medicine in the county was told you cannot buy from any other place, you can only buy from KEMSA. And that meant that even when there is an emergency, somebody will die, yet the counties are supposed to be providing top-notch health, waiting for medicine coming in from KEMSA. Governor Ruto always joked and said, and when we get the medicine from KEMSA, we get black Panado. I don't know whether there's really black Panado, but I guess that was a joke, to just say that the medicine never used to reach. So there's been those misses, not because the system is not working, it's because it's a new system and we are all trying to find our way about it. The only thing I would finalize by saying is the counties, as my brother has said, health is 99% devolved. Please have your conversations within your counties for what you want to surrender and what you want to keep to yourself. In the event that you decide I cannot manage healthcare, don't give it away as 47 counties. Do an intergovernmental agreement with the national government as county-wide alone, so you are not dragging everybody in your story. Thank you.
Thank you so much, Jackie. I think that's really well put, looking at the misses. And so I go to Prof. I hope you are not among those who got into the Prados to Multimedia University. But that notwithstanding, I really want you to give us your perspective in terms of health governance as a minister, taking into account the role of development partners and private sector. The big question is, who really calls the shots?
Thank you. Thank you very much. Let me go back one step. For me, I had an advantage because I had worked in the center for quite some time, and we were calling the shots from the center. Then I went to teach young doctors and young nurses how to implement health systems. Then I was invited to be a CEC, which I did for 5 years. So I have the experience of there and the experience of here. So that my learned colleague, when he is talking, I have the experience of both centers. But let me address my colleagues, CECs who are coming in. It is not a walk in the park. When you go there as a CEC, you have celebrated enough. Now get on your desk. When you get there, start with the manifesto of the governor. Get to know what has he written, because you've been appointed by the governor. And you are his officer, you are his advisor. The governor is the one who sits on the driving seat, bottom line. But because there are many other things, he puts you to sit on the driving seat for him for help. How do you empower yourself when you are sitting on this driving seat? Let me tell you, get his manifesto. Then the second thing, there is this CIDP which is being done. Make sure the views of the governor are reflected in the CIDP in health. Then once you have done that, then continue to know the strategic plan of the department, which is 5 years or so. Then after that, get to know the annual work plan, which is done by the department. Those 3 documents, hold them, and they are your Bibles, so that when you lobby for resources, you know what you are going to do. A partner comes. How do you know whether it's relevant to you? The first thing, ask him, were you part of the CIDP? No. The annual work plan, the strategic plan, the annual work plan, they say no. Then you might even offer to tell them, come in the second round. Because if you don't know the document and they were not part of it, they are going to drive the car for you. And when they drive this car for you, you will be in the forest and the governor will be tempted to fire you because you don't know. They will be dealing with the governor and leaving the minister. So that is. But then why do partners come and private sector come? Because there are gaps that you have already identified. In fact, you should invite them. You should invite them. Like here, they are here, you know, Wairimu is here. Call them. And when they come, be in charge. You are sitting on the chair and you have the documents. Tell them, I have the gap in HIV/AIDS. I have the gap in malaria. I have the gap in TB. Then you can now fill that gap with them. And they will come and you sign a document that they are going to help you implement your plan, not their plan. Then lastly, you need to know that you have to mobilize resources. And when I worked in the center, in '99, I led the process that developed the first national health sector strategic plan. When that was done for Kenya, that is what we used to go to Abuja, and then we put a cry for this thing which you see called Global Fund today, thanks to the late Kofi Annan. And then PEPFAR followed. And then Clinton came because we had our document and we were able to show the gaps. If you don't know the gaps and you don't know your document, they will drive the car for you. And partners are very good at driving the car for you. Every weekend they call you to a seminar and you fly to Mombasa and you feel good. And when you feel good, your governor is waiting. Thank you.
Thank you so much, Prof. Thank you so much, Prof. And I think a good thing that you've brought out is, do the CECs understand their gaps in terms of their funding landscape for health? What are their gaps? What are their gaps? So that now brings me to Wairimu, fully understanding what Prof has said about the gaps and the whole role that we know development partners actually complement or do some element of additionality. At what point, as a development partner, do you think these terminologies are not well understood, and hence the harmony in terms of that complementarity and additionality doesn't seem to work at the county level?
Thank you. Thank you, moderator, for that question. And speaking of, Prof has spoken about development partners, is not easy, but I think we need to just be clear what our roles are. And as we talk about change, is the way we think, the way we act, and also the way we are learning. And we are agreeing that we are learning from each other and we are supporting each other. You talked about complementarity and additionality. Now, you know my tongue has to work very hard to keep those in check. For complementarity, it means bringing two things together for a better outcome. What donors or development partners are bringing to the table is a conversation as much as it is about resources. We have agreed, Professor Muga, that it is now about having a conversation where government is taking the lead. Most development partners have been on this path for a long time. I think for USAID and others, I think we are now changing our language to be more aligned. We are talking about transforming our relationship, working better with counties, with the national government, and other players in the health sector to complement it. As you are saying, it is not about what we are bringing to the table, it's about what the country and the county are trying to do and how we come in with what we have, whether it's technical assistance. We are complementing, correct. We are helping each other for the greater good. If we understand that it is about complementing and not taking over, I think that helps because the donors have resources, they have technical capacity in some areas. It's not that the country does not have. I think we've reached a point where we are saying, in fact, we are saying you don't need to go anywhere to learn what is a best practice. It is already here. But how can we complement by taking it to scale? Which brings the question you asked about additionality. What is it we are adding? We are adding what we have, which is the resources, maybe some technical knowledge, but what we are trying to do is take things to scale so that everyone is reached and the goals that the country have set, which is now UHC, everyone has access to. I had top-notch health services at affordable prices, or at least they are not going into financial difficulties. Because we now have a common goal and a common agenda, it is not difficult then to work together, to complement each other. And as you were saying, it may be the partner, the government or the county approaching the donor. It doesn't have to be USAID, it may be any development partner with their priorities and their gaps. And what we are doing is to work together. Do I have resources? Now, Katra, I don't have a lot of money, that is for sure. But with whatever resources I have, can I complement what you have? Can I add? Is there value I am adding? If I'm not Professor Muga, you have every right to say that is not working for me. So the threats, I think, and the conflict arises when we don't have a common understanding of the goals and the objectives of why we have the resources we have or why we are trying to work together. I think you've laid it out quite clearly. The country has a vision. The country has a strategic plan. Counties have plans, CIDPs, they have annual plans. How did I, as a donor or a partner, engage in that process and so understand what you're prioritizing and what am I bringing to the table to complement that work? That doesn't mean I don't have some goals of my own. I think we need to be clear about that. At this point in time, donors are struggling with resources, especially that now that Kenya is a medium income country, then resources become limited and they are moving elsewhere, or resources generally are limited. So what we are talking about now is transition. So we are working together towards transitioning what we've been supporting over time, because capacities and abilities are already within the counties. So we are working together, complementing, adding value, creating harmony. You talked about music. Music is about something that is pleasant to listen to. And hopefully the health sector is a place where people will say that is working well. It is devolved, it is complicated, it is very complex, it is resource challenged, but it is creating harmony and getting results. That's all what we want. Thank you.
Thank you so much, my panelists. I think now I will I'll leave the podium and come to the ground. We have listened to these great minds, giving us very good insights around crowding out effect, around misses and gains, around who is on the driver's seat, around harmony. So I'll need somebody to help me with the mics. I would like to hear some rebuttals from this end. We will go two here, two here, two there, two there. Then we see how the day goes.
Thank you very much, panelists, in particular, Justice Mogeni. I thought it's prudent that I give a testimony about you, so we are not wishing you bye-bye. But one area that gave a lot of exposure between the national government and the county government, and you played a very critical role, was during the COVID-19 pandemic. I think this is one area where, at the national level, we discovered that there was nowhere one could go except within the county. Remember the time we had the borders closed, no governor could fly out of the country, and even the president, and therefore people were confined into their own areas. This is something that I learned a lot of managerial skills from you, where we discussed, and you just put it clear to the national government. It's only capacity building at county levels that we're going to manage the pandemic. And I felt that you stood for the counties, and out of that effort, I think the national government went down to support counties to manage the pandemic. The CC Kajiado is here, and remember Kajiado, Machakos, Nairobi, Kiambu were the epicenters. And for this, I just want to say that the lessons learned were that we should strengthen healthcare systems within our counties to a level that, not due to pandemic, to a level that we can have a facility within the county where the who is who in the county can go for healthcare. I mean, I look at it because every governor would go to Nairobi, and probably Kisumu, you have some facilities, and Mombasa. But other counties, I can tell you for free that no governor would seek health services within their facilities. So this is something that I want us to grow from what we learned from pandemic, COVID-19 pandemic, and then see how best we can have a center of excellency in every county, where the who is who in that particular county can go and seek services. One of the challenges that we have in our counties would look like the supply of pharmaceuticals and non-pharmaceuticals. And this pushes our clients from our government facilities to private facilities. So it's something that we need to look at, and I'm happy that we are all here looking for best lessons learned, and I thought it was good that we also link what we learned from COVID-19, that chako ni chako, si cha mwenzio, hata kama ni matambara. Asante.
Thank you very much. I will ask, are you the youngest CC or the oldest?
All right. Thank you so much. My name is Dr. Umbati Timothy Mokua from Nyamira, CC Health in Nyamira. I think, Lady Justice, I think I am your CEC. Well, there's one area I wanted to understand. It was shared previously by the previous speakers, the role, how we interrelate between the county governments and the Ministry of Health, especially on some key areas. And I've loved the way, Daktari, Professor, you said you're on this side and now you're here, and you've been moving through that. Because sometimes you'll realize that, and I'm happy at least there is some improvement on that, but we need to have a better way of interrelating. Finally, the gaps within the counties and how we have realized there are some areas where the partners, we have a few partners. In Nyamira, where I come from, we have like 2 or 3 partners, and you go to some other areas, there are more other partners. So I wanted to understand what are these areas that as Nyamira we've not touched for us to get other people who can support us in the running of our services. Thank you.
Thank you. I will come to this group.
Good afternoon. My name is Dr. Amalwa Andrew, CC Health Bungoma. I have a few concerns.
I would wish that even as we raise them, please let's make them very brief and to the point.
Yes.
That's the high table. Sisi ni watu wa ground, eh? Chap, 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 chap.
I'll
Really
be very
appreciate
brief.
that.
One, my concern goes to the lawyers in the room, Lady Justice and George. Can counties establish SAGAs, semi-autonomous government agencies? And in this regard, I'm talking about KEMSA, because there have been questions here around fill rates and inefficiencies emanating from KEMSA. Or can KEMSA devolve its functions so that we have KEMSA in every county? Another concern is, and this was presented by Dr. Amalwa, about KH-Power and other regulatory bodies. I've been a health worker and I've experienced it firsthand. KH-Power trained health inspectors to do assessment of healthcare facilities. However, the tool they are using is electronic. Data goes straight to KH-Power. So at the county level, you get complaints. There is a recommendation to close facility A or facility B. You can't intervene. You are the CEC, people are complaining to you. But the KH-Power is the custodian of that data using county health inspectors. So, and then two, as a county, our role is to implement county health services, but we don't have regulatory roles. How can you implement something that you can't regulate? This is a function of the national electoral bodies. So when the law says you can't visit or you can't inspect a health facility without someone from Kenya Pharmacy and Poisons Board or Kenya Medical Practitioner Dentist Board, Dentist Council. So we are seeing that there's conflicting issues there. Another thing is about, and this goes to the PS, Madam, port health services or port of entry services. Bungoma hosts a port of entry in Luahaha. We have seen that the national government only comes down when there's a threat of Ebola or other communicable disease from our neighboring country of Uganda. There's no step that has been taken by the national government since devolution to ensure that the port of entries are protected. So my question to Madam is, what are the efforts to ensure that the port of entries are well protected under the national government? Thank you.
Thank you. Anybody else from Group B? If not, we go to Group C. Dr. Eda. Who has the other mic? Can we move a bit faster? Dr. Eda here. Please listen to the moderator.
Thank you very much. Mine are direct questions. The first two goes to Madam Wairimo. USAID largely does engagement indirectly with NGOs and CBOs at the county level. Yet, majority of the time, it is more efficient to directly deal with county governments as people who are actually giving that direct services. When will you review that kind of policy, if it is a policy or it's a direction? Two, the donor partners are transiting, like you have said, and we have all also said. But Kenya is coming out of a very difficult post-COVID-19 pandemic economy, disastrous climate change hardships that is affecting very large part of the county. And I can specifically mention my county where currently the county is struggling with a drought that has never been seen for 40 years. And we have got maternal malnutrition levels of between 50 to 60%. Against this kind of hardship that Kenya is coming out, is it possible to start, sitting down as partners and maybe work a little bit longer with Kenya, especially as we go towards Vision 2030 and as we go towards making primary healthcare and UHC a reality? That is my two questions to Madam Wairimu. The other question is to Mr. Josh. Within the context of law, how better can issues such as the Cuban doctors' importation and mess equipment be done better so that it is acceptable undertaking to both levels of government? Thank you.
The gentleman in the flowered shirt.
Thank you. This gentleman is from Taita Taveta County, and my name is Gifton Mukaya, the CC for Health Services. I just wanted to make some remarks concerning the infamous meeting at Multimedia University. I was a participant in that meeting, and I think colleagues, yesterday we got some advisory from one of the presenters here concerning some of these meetings which are organized by the national government, specifically Afya House or Ministry of Health. Then we didn't have an arrangement where communication will be done to COG, and then now we are invited for meetings. So we are directly invited to that meeting. I didn't travel in a Prado, but I was there. So you can see the danger of what happened then. So whatever we were told yesterday, let us take it seriously that every meeting that we are invited, can it go through COG? Because I'm still seeing there is also another danger, because even though nowadays the communication is going through COG, but for example, you see maybe the directors, the county directors of health are invited for a meeting, but before this communication reaches COG, it's already in the hands of the county directors of health. So my suggestion is, can the communication get to COG? Let COG look at the objectives of that meeting. Then if it is okay, then can they forward the communication to counties? Otherwise, a similar mistake may be repeated, where we'll end up in the mess. So I think that is something very key. Madam Jacqueline Mogeni, you did a good job. I'm one of those CECs, the pioneer CECs, though in the second generation I wasn't there, now I'm in the third generation. So those of us who are coming in, can we ensure that these county directors of health, or even our chief officers, when they get information, let it come directly to the office of the CEC before it is now marked to the county director of health, instead of it coming straight from the national government and direct to the county directors of health. Otherwise, we may end up in the same mess again. Thank you.
Very well put. The next gentleman, please make it short and align it.
Okay, thank you. Thank you. My name is Albert Taiti. I'm the CEC Health Laikipia. Maybe I just want to address one or two things. One, and more so to the development partners. And one of the things that I want to address, now that it is very clear that they are transitioning, and which is okay, to go and help those maybe who may be having more challenges. What are they doing towards supporting the process of sustainability on all those projects or whatever they have been doing? Otherwise, they need to take advantage of what those who deal with physics say, hidden momentum of growth. You cannot just stop and assume that things will be okay. They will not be okay. Of course, the other thing I also want to address is that you have been around, and this is not just for you, all partners. And I don't know what they normally, how they normally handle some of the counties that have two faces. For example, Laikipia. You go to Laikipia North is even worse than Samburu, it's worse than West Pokot, it is worse than Isiolo. But it is normally, the whole of Laikipia is considered as part of Mount Kenya, where maybe even the partners normally have very little business to do. But right now we have a lot of challenges there. And of course, if you go again to the east and west, it is more like central Kenya, where the disease burden is purely or more of non-communicable diseases. So I think for those who will be remaining before the transition completely, I think they need to look at such counties which have those double faces, because even when we were talking of different partners calling some of the counties, Laikipia is not called anywhere, and we have more challenges than some of those counties that have been called. Of course, the other thing, and this is I may be forgiven to ask this, and this is from the partners again. Do we normally or reward poor indicators? Because Mount Kenya region has not been supported in many ways. You go to other places, they remain with poor indicators from time when I was born to this time, and a lot of money is being put into some of these counties. I don't know whether it is by design or what normally happens there. Maybe what we could also think, can we also reward some of those counties through strengthening their health systems? We may not have disease burden, but we still want to strengthen our health systems. And I think that one is also what could help you to comfortably transition. And even if you don't look back, things will still continue. And again, finally, as we think of the issue of resource mobilization, and also as you transition, I think we are capable, and looking back at what happened during COVID time. I was part of the technical working group and National COVID Fund, and also supported by Equity Group Foundation. And for sure, for those who followed, and the health workers can attest to this, we were able, through the support, we were able to provide PPEs. We were able to bring down the cost of PPEs, and even encourage local manufacturing, and even train health workers, and even do psychosocial support with very little money, and as compared to what the national government had. I don't want to go to those old stories, but everybody knows what happened. So I think there is a lot the partners can do for us as they transition, so that they can leave systems that are working. Thank you so much.
Gentleman at the end, I think the one before my classmate.
Good afternoon. My name is Dr. Kibor from the Ministry of Health. I want to acknowledge the presence of my peers. I'm from the Partnership Coordination in the Directorate of Health Sector Coordination. My question is directed to Professor, who has worked in both the national level and the county level, and now in institution of higher learning. We've heard about capacity building, human resource for health, and we know universities have a critical role in this. Almost all of us, actually all of us, have gone through there, and we'll need to improve on continuous learning when we are in the counties, and our staff in the counties, and even at the national level. How do we promote this linkage, because they are important partners as well?
Yes, my name is Nzoya Munguti from USID. I just want to project what Professor Muga talked about on the need to be very strategic as you start your work. You are coming in at a point where there are so many processes that are running now in counties. Counties are developing their CIDPs. At national level, there is also this process of the medium-term plan 4. And more importantly, counties are now doing their medium-term expenditure framework. Professor talked about these instruments that you really need to pitch the agenda, government agenda, and also for the governor through in the CIDPs, but he didn't tell you why you have to do that. It's important that as counties do their budgets now, to align, to make sure that whatever priorities that are reflected in the CIDPs, in the annual work plans, find their way in their medium-term expenditure framework. Basically, this is a budget for the next 3 years. Anything which is outside that, you're not going to get any funding. So you make sure that as sectors develop their budgets, make sure that you engage and make sure that county priorities find their way in so that they get funding from the exchequer. Thank you.
Zoya, but there's a lady whose hand has been up since morning. I'll give an opportunity before I go to group 3. The lady in yellow.
Thank you. My name is Claire Parclair from West Pokot County, CC Health. So mine is just a concern. I'm from that county, and I have a concern now that the NHIF is a compulsory thing. And my people in that county are either in Kenya or Uganda. Some have 2 IDs, the Kenyan one and the Ugandan one. And most of them, especially the northern part of West Pokot, most of them have the Ugandan IDs. I really don't know how my people are going to be captured because registration is going to be very low. And especially now we are among the counties that are doing measles campaign. And most of the children are just in the other side of the Uganda. I don't know whether the Ministry of Health is doing something about such counties who just crisscross. They go to Uganda in the morning for shopping and in the evening they sleep in Kenya or vice versa. Thank you so much.
Thank you. Let's go to group D.
Okay, thank you. My name is Dr. Kotut Sam from Uasin Gishu County. I'm just going to make a comment on the presentation by the USAID support in Uasin Gishu. I want to say that we are doing very well. It's just a comment, and I want to say that the partners in Uasin Gishu are really working well in UG County, and the people we are working with, MTRH, AMPATH, and the adjacent counties of Busia, Elgeyo Marakwet, we are doing very well. I want to say this is something good. Other counties can borrow this from Uasin Gishu County, and USAID, Danida, CHAI, and other partners in the county. We are doing very well in the service delivery within the county. I want to say also that it was our requirement that in the MTEF4 and CIDP, which we have just concluded, it was necessary to embed this in the development of project service delivery in the facilities within Uasin Gishu County. So thank you very much. I think the work is going on well. Mine is just a comment.
Thank you. Just before you sit, I want you to tell us, when you say you're doing very well, are you complimenting,
Yes.
adding, or you're just surviving on them?
No. We are complementing. We as a county, we are voting in funds to complement the work that is being done by the partners. Because you realize partner support is dwindling, and partners are also not going to be here forever, and so we are aware about this. So this is a compliment, and I want to say that this is additional and complementarity.
Lovely, lovely. Anybody from Group D? Okay, if we do not have Group D, there was one lady I had left on this end. I will allow you. Sorry, but you can see where my bias is. I just love ladies.
Thank you for remembering me. All protocols observed. Good afternoon. My name is Melissa Wanda. I lead Kenya's Advocacy and Policy Program. Mine is more of a reminder, right? There was a discussion around the health sector partnership and coordination framework. And from where I sit, and as an advocate for health, I ask myself, how well disseminated is this framework? How many of us have had a chance to interact with the framework? Our CECs, those who have been in the health sector, apart from the high table, I'm sure some of us have interacted with it. Yes, thank you, Prof. So it's just for those of us working from the national level to ensure that the frameworks and the guidance that we have from the national level actually get to reach down to the counties. And this is just to say that some of the counties have really been on the front in ensuring that they contextualize some of the frameworks that come from the national level. And so there are lessons there that can be learned, and looking forward to working very closely with COG to see how those lessons can be scaled up and other counties can learn from there. For partnership coordination, we also have the shared, there was a discussion around the shared resources. So how do you coordinate partners who are working in a block of counties? And I really appreciate what Waziri has just mentioned, the one who spoke before me. Those shared resources. So how do you coordinate the partners who are actually working in a block of counties and they are supporting to deliver on specific priorities? How do you coordinate those partners? So going beyond just county level coordination and national level coordination to even those clustered kind of coordination. Thank you.
Thank you very much. I think coordination is coming back again. My brother next to Yumbia, who gave Yumbia all the leakage in the exam.
Thank you very much. My name is Kariuki Kishuki, the immediate former CEC Nakuru and now CEC Health Nyandarua. The issue of money is everything. You know, health runs on money. And we must start thinking about how we shall make money so that we are able to, all the things we've talked about, actually all of them will require some money of some sort. And therefore, going back to FIF, and how we implement it and how we actually keep the money is a very big deal. I want to give you free advice. In Nakuru County, for the last 3 years, they've been able to move from 500 million FIF to 1.3 billion. And that means when like there was COVID, there was no problem because the money is in the health facility. In fact, by the time the national government gave them money to buy PPEs, they had already bought enough stock for a very long time. There is no problem in paying KEMSA and everything. And therefore, we must start thinking, how do we make money? Because it is the responsibility of the clients we serve to also think about their health by either enlisting in NHIF or any other social system and not the out-of-pocket thing. And I think one of the things that we require from partners is to assist us to be able to go out like in Laikipia County to enlist a lot of people in NHIF. When all is said and done and when this conference is over, health will still run on money anyway. Thank you.
So much, Waziri. I'm so tempted to move you there, but just stay there. Katra?
Thank you, Regina. Thank you to our panelists. I feel that some of you will have been here from day one because I'm hearing good stories even like the history of maize has clearly came out from our former CEO and Professor Muga. So, and I think this is some of the things that we are emphasizing. You've been taken away by Prados, you go discuss, and then you make decision on behalf of the 47 county government. I really love that discussion. And I know after this, because we have wealth of knowledge from our former CEO, I think some of the CCs, you can be able to have time and actually interact with her. My question now goes to Wairimu. I know we have a lot of challenges in terms of partner coordination, and I really want to echo what even Nyamira CC has said. Recently, we had partners from health finance space coming together and having a discussion and that came as a result of, you know, a forum that we had with 15 counties who are supported under COG. But we wanted to escalate this. And then just when we brought them together, we realized that we have 42 partners. In the 42 county government, we have partners working in the health financing space. And then in the same forum, we are having partners who are working within the same counties, but they don't know each other. A lot of duplication of efforts. And I had to just go around and give them mic to tell me where they are from. So you find 3 partners working in Isiolo County doing the same thing, but they don't know each other. I know as a partner, you talk together. Partners in health space, you talk together. How do you think, what are the innovative ways of actually taking charge of this particular problem so that we have it ended? Because like it is a discussion that has been ongoing. Most of the partners are focusing, you know, they have their interests. They focus on 1 county or 2 counties and leave other counties behind. And now that we are talking about equity and equality, what do you think? What do you think that we need to do differently? Because for us, I know as COG, we are trying to do donor mappings. And like we find a lot of partners concentration on some regions, and some regions are left out. Specifically ASAL counties, in terms of insecurity, you know, we are not allowed to go that side. You know, we are not allowed to go that side. A lot of excuses. And I believe like also there are Kenyans who come from that end. Now you're representing the partners and seated there. What do you think you need to tell us? Maybe so that we can be able to end this problem once and for all. The problem of partners now within the counties, they only now go and see the leadership when the issue of sustainability is coming in and they are pulling out of that particular project. The project has ended. Now we are looking for a governor to tell him, I've invested 40 million in this space, I want you to take over. But during the entry into the community or the county, you've never had that forum to actually engage the governor. So it is something that maybe you need to tell us, what is it that we need to do differently? Thank you.
Thank you, Katra. I gave you my mic, but you used all my airtime, so I have none. I have to take this thing back to the podium. What I'll request my panelists is to respond to any questions that they deem fit for them, and at the same time, please give your punchline so that we finalize on this session. So we start with Wairimu. You seem to have had the most questions.
Yes, I hope you can hear me. Yes, I seem to be very popular. Even the last punch was very hard. Wow, Katra. I want to say I'm not alone as a development partner in this room. We came a very big team from USG. Everyone from development partners, please stand up. We have a very strong team from CDC. They support many of the counties. Please stand up. That is CDC. We had DOD. We had USAID. I'm not alone in USAID. We have Peter, we have Munguti. I don't know where Dan Stan is. So please, if you need someone, and Victor from DPHK, in fact, all the issues around donor coordination, I call you Victor, Vincent, is the right person to ask. So we are here, many of us, we are listening to the same conversation. I just happened. And as usual, the mics go off. I think when you shout, they go off. So let me talk softly. There are many very good questions and concerns about donor engagement in Kenya. Of course, there's a history. We are not talking about a blank slate when it comes to what we are talking about transition. I would ask even if any one of the people from the donor partners would like to add something, they can. I think it was yesterday that Brian from PEPFAR mentioned that the transition is being done responsibly. We are being as responsible as possible. We are not just exiting and saying kwaheri. With reducing budgets, we are diligently working with counties and partners to see what reduces as we move along. But at the same time, there are conversations happening at all levels with the national government, with county governments, bringing awareness to the implications, bringing awareness to the need to step up now that we're in planning phases, whether it's MTP4, whether it's the CIDPs. Let this begin to show up that the counties are taking more and more responsibility. And what is it for? Peter Waidaka there is in charge of HRH for the USG and has been in very many discussions about how do we calculate what we need and how to reduce dependency. So we are doing this responsibly and working through at all levels. I know the issue of partner coordination at county level, I'm taking one or two, I'm not taking all of them, is a big issue. I really liked the discussions this morning about the framework for coordination at all levels. It is there. The question is how aware are we, the good question you asked, but how does it work for counties? Because I think a lot of it looked upwards. How does it look down? How does it look like for counties going down rather than up? So that the issues are percolating from the patient. We said yesterday, let's focus on the right person going up. I think there are issues there to discuss and to disseminate. I am aware that issues around the partnership and coordination framework also, I think it needs to be reviewed regularly. My understanding it's a living framework based on what we are learning. And I really want to underpin someone saying that partnership, even complementarity, is based on trust and a willingness to learn. If I am not learning as a development partner in this space and you're not learning from me as I talk and as we have this conversation, then something is wrong. Because we cannot sit in our space, things will change. I think we are all learning at the same time. So for the hidden momentum of growth, I didn't do physics, but I understand that is that, yes, we understand. We've been here for quite a while. The trajectory is changing, but we are being responsible as this trajectory changes. We do understand the counties that we've worked in that is an issue, but even for the counties that we have not worked in, the question is still there, you have heard, then what happens to us? With finite resources, we can only do so much, as someone mentioned yesterday. And therefore, sometimes we make very hard choices, some of which are not everybody will understand and be happy with, but that's what we have to deal with. But I think these conversations can continue. USAID, I'm sitting here as USAID, but as we have representation from other partners in different counties, please continue the conversation. This is not a quick answer, and we also said the context of each county also counts. So the conversations we are having with the partners at that county level to understand the trajectory. My mic has refused, so it's a good time to stop. Thank you. So we continue to work together. I think that's the bottom line. Okay. We are in partnership with all of us.
Thank you, Wairimo. We continue to work together. We are in partnership. That's the punchline from the development partners. Prof.
Thank you very much. Let me add a word to what Wairimo has said. Some of us who know the history, there was a time in this country where all hospital beds in many district hospitals were occupied by HIV/AIDS patients. And they were dying. If what happened did not happen, if PEPFAR did not come and Global Fund, I do not know what story we would have today. But today, when you go to many facilities, the beds are occupied by cancer patients or, you know, even malaria is going down because of this massive investment. So I am sure they are still cognizant to the fact that a good job has been done. And when we are transitioning, they are not just going to say we have taken the plane and gone. I thought I should say this. But let me come to mine. There was a question which was raised and nobody has answered, the research clearance. Let me give you my experience. The person or the organization allowed to give research permit is NACOSTI. When you are a CEC and they come, somebody comes in your county, ask for this. Where is the clearance, ethical clearance? And then where is NACOSTI permit, which allows you to do research in the county? Then thereafter, you can now ask, where are you going to keep the data? How are we going to benefit? Then you can sign for them, then the research is being done. And the permit does not exclude even Cambridge. They still have to look for the permit from NACOSTI. This is very important. Even us who do research in the university, we do the same. So as a CEC, what do you look for? Look for those that I have suggested to you. Then a question which was raised by Dr. Kibor, what can universities do? I teach at Uzima Medical School. We teach doctors, nurses, clinical officers at degree level. And then there are other universities who teach. Now, we need to create partnership with the national government who has the mandate for training so that we can decide which courses, how do we build capacity to the staff. And CECs will have to take a lead because you need to know who needs to have capacity built. And then lastly, I have the other questions have been raised, and Wairimu has answered, you know, why are they not in other counties? And you can find the answer. Don't cry for them when you don't have AIDS, you know, because when you have AIDS, it is very serious. But now, counties which did not have HIV/AIDS, they are now, like Nyeri, somebody said, we are now beginning to see non-communicable diseases. We are seeing a lot of cancers, and we believe that the process will change and it will begin to address this other disaster that is coming. Finally, what is my take? I teach, we have the experience, and we would be available if there was need that we can support our new colleagues and try to build their capacity. I can see Yumbia. Yumbia was my officer. He has grown very well. When I was DMS, I made him the, and he has done an excellent job. Now I have handed over the baton to him that he can run in Machakos, and there are many others. So we are there for the next few years remaining in our lifetime. We can help. We can assist you. We can try to come to your county through COG so that we can help you, so that we improve the health of our people. And I will pass to you advert for calling students through COOPs to come. We teach for you, because we will teach them to become better health managers in some of these universities. I thank you.
Thank you, Prof. Jackie.
Okay, very briefly, maybe to start with is just to echo what Professor has said. If there's no problem in your county, please don't ask for development partners to come, because by the time they are coming, you are dying. And so my brother from Mount Kenya region, maybe you could look at what is it that you do best, and so that you can promote health tourism like India. So build the best facilities. It's true during COVID that, for example, Moranga did very well in the hospitals that they built and the facilities that they had. So please don't ask for a problem. In fact, touch wood. People usually say touch wood. Touch wood, so that the people from Mount Kenya don't say that you are praying bad things to happen for them. You're doing very well. Continue like that, because it is traumatic to see a population that is really, really sick. So we applaud the Mount Kenya region for what you're doing. Look at the strategic areas for intervention and let people be saying we are going to Mount Kenya area for treatment for this thing because their healthcare is very good. On the issue of assessment, we fought with Yumbia a lot of times when they were going to the counties to do assessments by themselves, and I said, stop it. You can't do that because the counties are in charge. And I know that standards is the work of national government, but remember the people who are on the ground are actually the CECs, and so let them give you the team. You remember Dr. Yumbia, yes. So continue to work with the institution that is doing standards because that's the work of national government. But what we created was a framework to ensure that they are not going to do assessments and closing hospitals without your involvement. And it is good that actually we have facilities that are meeting the standard. As he said, governors do not governors do not want to go to the hospitals in their regions because they've not built their standards. So you work with the institutions so that you build the standards so that we all can go into those facilities because we should be able to access healthcare anywhere. Like for example, as judges, we are posted all over. I should not be a judge in Garissa and I have to travel all the way to Nairobi for treatment. Garissa should be able to offer me what I am looking for because health is 99% devolved. So build that. I always remember, I ask myself, what was the reason why this issue of standard was created? Has it worked? Has it not worked? And what has worked, let us speak on it. For us, for example, in the judiciary, we always used to just hear cases and somebody's winning or somebody's losing. But now we are embracing what we call the alternative justice system, AJS, and we keep saying if your community had a system where they resolve issues, we always pick, for example, the example of the Somalis in the north. When you kill somebody, and that's murder, of course in the Kenyan system, we'll have to lock you up. We're only locking up one person. We're not going to resurrect the person who is dead. But in their traditional system, the AJS, they would make the person who killed to pay 100 camels. And so and of course, in the court, I'm not going to ask you to pay 100 camels because the law doesn't allow me. But I'm allowed to refer you to the community so that you can be able to go through AJS and resolve the issue. So instead of closing the hospitals, let us look at an AJS mechanism where we say, what is it that is missing? Let's improve and put that in instead of closing. Because where do those people go? If you close the hospital, they have to go to very, very far to look for a hospital. So that is something that you can interrogate. Then on the issue of counties facing out the development partners, I keep saying, like when Danida came to us and told us they are facing out, what we negotiated, what was Danida doing, we looked at that, and how long do we have? We have 5 years. So what we negotiated with them was to say, now, within these 5 years, let us do a complementarity so that the counties begin to now pay. If Danida is putting in 20, the county also puts in 20%, not 5. Why? Because what you are using was 20 of Danida. So you put in your 20. By the time Danida is facing out in 5 years, you don't need Danida anymore. Because you've been putting on consistently what Danida was putting in, and now double. So as Danida faces out, you are able to move on. Donors will always face out. Look at what they are doing and begin to complement so that you can do the shilingi kwa shilingi or shilingi kwa shilingi tano. So that when they are facing out, we are okay. We are really cushioned because these donors can shock you. Tomorrow they just come and say, our capitals have said a different thing. And the last one is it possible that KEMSA can devolve and counties can do sagas? The answer is yes. It is in the law. Nothing stops you, including those FIFs. Because I know Kakamega County did it already. So I keep asking, what are the other counties doing? And I know you have a problem with this MCA problem of, yeah, you understand it. So it's up to you to be creative and ensure that it passes through your MCAs because it's just for you. Because other counties have done it. Kisi did it. Kakamega did it. I don't know which other county has done it. And it works really, really well. And yes, KEMSA can be devolved. We always say in law is not absolute. There's always a gap. And the ones who make the laws are here. Look for the gap. There is a loophole. Look for it, utilize it, and make it work for you. And there's a very close linkage between good health and environment. So don't forget the environment and land court in your regions. We are in 37 places. Please reach out to those judges so that you can also be able to work together with them for a healthy community. That's my take home.
All right, thanks, Jackie. I was thinking you're going to give us one major kicker, but to Josh.
Thank you, Jackie. In law, we say without prejudice. So any comments I'm going to make, I'm making them without prejudice to my seniors, Jackie, Professor Kangu, and any other senior lawyer in the room. I have 3 points. One, policy precedes legislation. You cannot amend a law if you've not exhausted all the policy options. And therefore, the fact that KEMSA Act was amended to ensure that only KEMSA provides or supplies medicine even to counties, there was no policy at that time. And we urge as Kenya Law Reform Commission that you have to ensure that policy, because that's when you can involve the people in policy discussions, should precede legislation. That's my first point. The second point I wanted to make is that the framework for engagement between county governments and the national government and their MDAs is very clear. The law is there. What we need is good faith, meaningful engagement. Good faith, meaningful engagement. When we were implementing the Constitution, we had this problem with people who work in the national government. And it's still there. We are not, some of us are allergic to change. The Constitution has given the county government some functions. But when you are making law or policy at the national government level, you still insist on retaining some functions through the back door. So that means there's no good faith, and then the paradigm shift has not matured. The third point I wanted to make, and Jackie has mentioned this, is that please, as county government CCMs, please look at Section 6 of the County Governments Act. County governments are constitutional entities. They exercise constitutional authority. Please don't be afraid, because Section 6 of the County Governments Act gives you all the powers that you need. Thank you very much.
Thank you so much, my panelists. I think this was really a very good session. I will ask that the audience please be upstanding so that we give them an Obama clap. Did you have a comment? She was asked that question. Without prejudice. Okay, then without prejudice, allow me to give the PS my mic.
I always say this, and the low guys are in the class. Health was devolved, but we did not devolve health needs. As Justice said, you can be sick in Isiolo. I think the question I'm looking for is a seamless relationship. How do we ensure that level 1 and level 2 up to level national, because there is 3, 4, 6, we are talking to each other? Since I came here, I'm hearing problems. I think we are the same people who have solutions. Nikweli, we are the governors of that county, this country and the governors of the county. I was trying to consult her, and I think Health Act 2017 has something on consultative forums, whereby there will be a lot of cooperation, coordination. And I think this is the time we implement what is written. Maybe majority of us, even the CC, have never opened the Act, Health Act. Maybe we have not even read. And I'm tasking her, every time you have a quarterly meeting, let's have a consultative meeting. Let's bring the professor who has been in and out. At least me, I've been out, not very in. So that the emerging issues, we tackle them. Let's not cry off outside, but when you had the chance, we did not address. We have these guys who are interpreting the law. I was telling her, when we were being interviewed, it became very difficult to read those articles, the 4 clauses of the governance and what. You need the lawyers to tell us without personal interest. And once we let the guys who are authority in that area to guide us, and then we work together, talking to each other, I believe everything is possible in this country. And we'll change the health service delivery with a paradigm shift. Let's not be judged. We came, we complained, we did not change. The little change you start today, kindly, let's start with it. Let's not climb from the tree, let's start from here. As I said, we are all new. And you learn a new thing. Every day you learn a new thing. With the partners, I think they are doing a good job. Let's not dismiss. They are really supporting us. The question is, who is going to coordinate us from the gaps we have so that we can widen and look for more development partners? But as they leave, we are able to sustain. Because sometimes they leave us without unsustainable framework or maybe plan. I think this is a wake-up call for all of us who have come here today for induction. Let's take the positive things. The negative things, please hide them first. Let's not look at where the resources, let's understand, internalize, we conceptualize, then we sit with these guys and maybe they might advise us better. That's my take home.
Thank you so much, PS. I think the positives are what we really need to focus on. Can we clap, give this team an Obama clap? Before I go there, Muka, I'm part of that photo group. Eh? Can we clap for these people, an Obama clap? We just clap and then when they sit down, we stop. Let's start. So, no, you're taking a photo here. Do we stand for the photo? Yes. And we did the PS on this photo. Keep clapping, keep clapping. Thank you very much. My panelists, thank you very much. And I think from here we can, I've just been informed we've all earned our lunch. Enjoy your lunch. Bon appetit. So lunch is 1 hour for lunch.